Good
Yeah.
evening and welcome to the next webinar by AMR Declaration Trust. AMR Declaration Trust is an NGO working in the field of antimicrobial resistance, and we have been organizing webinars and academic activities over the last 3 years. And this webinar is done in collaboration with Learn with Dr. Akshatha. And Dr. Akshatha is a young infectious disease physician working at Manipal Hospital. And Dr. Akshatha is very active in the academic field, teaching, social media, YouTube, and we are grateful to Dr. Akshatha in coordinating this meeting in a very comprehensive way with plenty of faculties, very interesting topic on controversies in antimicrobial stewardship. And we also acknowledge the contribution of Viatris and Pfizer in providing us unrestricted educational grant so that we can conduct various webinars without charging any registration fee from the attendees. Akshatha, Dr. Akshatha, over to you.
Thank you, sir. You're too kind. And again, I would like to thank AMR Declaration Trust and Abdul sir for giving me this opportunity and making my life easier in organizing. And again, I would like to thank the organizing committee of this as well. So without any further ado, let's start. So today's we are going to have like unique session. So basically, we have always discussed AMS as and most of them find it boring and they are not interested. So just to make it a little more interesting, I thought of having this series of controversies. So this is in continuation with the debate series which I had. So AMS is a field which is constantly evolving, and today we delve into some of the most debated topics with an exceptional lineup of speakers, each bringing their own expertise and perspectives in the discussion. Before we begin, there are a few housekeeping rules. So we'll each topic will have two speakers. So each will be presenting their argument for the first 10 minutes. 10 minutes each, followed by 5 minutes of rebuttal. And there will also be pre and post debate poll where the speakers will where the audience will respond. So I hope all of you are active. So there will be polls which will be there, and so stay engaged and share your thoughts. And definitely the chat, you can interact to us through your chat as well as the polling section. And also this session is being recorded and will be shared for your reference later. So let's see if I can start the polling. So the polling will be done on the VVox app. If anyone of you are not familiar with it, so you can just scan this QR code, or you can just type in vvox.app in the Google and enter this session ID, this number, and you will enter the polling. So I hope people have joined. And in case you missed joining through this, all the poll questions will have the session ID on top. So you can always enter the code. So let's start with the polling then. Let's see how many of you have joined. So this is just an intro question. Mayank, have the participants joined? Okay. So let's just end here. I think people are yet to join. Okay. We have some responses. I think people will join shortly. So for the first topic, we have carbapenem-sparing strategies, a futile effort or the future of stewardship. For this, we have Dr. Abhimanish, who is Associate Professor in CMC CMC Vellore. Sir is a renowned ID specialist, and I think he requires no mention. And sir will be talking for the topic that Carbapenem strategies are required, whereas I was trying to speak against the motion. It's a futile effort. So let's do the pre-debate polling. So for those who have not joined this now, you can just type in vworks.app and enter the code to join the poll. So we have some responses. Okay. Are you in favor of Carbapenem-sparing strategies? Is it a futile effort or future of stewardship? Okay, we'll just end the poll here. Okay, sir. Over to Dr. Abhimanyu, sir. Sir, I think most of the audience are in favor of the motion. Sir, over to you, Dr. Abhimanyu, sir.
Thanks, Akshata and Dr. Gappu for the opportunity. And what I'll do is let me just get my slide sharing. Can you see my slides?
Yes, sir. Yes, sir.
Yes, sir. We can see your slide.
Okay, yeah, that's good. So I think the thing I'm most scared to talk, the scariest this thing is about debates, because that means the truth lies somewhere in the middle, and there's no absolute truth in one argument. So what I'll do is I'll try to give a sort of a balanced view. What are all the problems and possibilities with carbapenem-sparing strategies as of today, and where we need more evidence? Maybe I would talk for the next 10 minutes. So first, simply, what is the best evidence we have in this area? I'm sure anybody who is interested in ID would know this fantastic RCT that happened, I think now 6 years back. So they took patients with bloodstream infections. They had two clauses, importantly. One is it should be ceftriaxone resistant, and they said that they should have piperacillin tazobactam susceptibility. So this is a definitive therapy RCT, not empiric therapy. That was multicentric and a non-inferiority design. They said that the non-inferiority margin was a very good margin of 5% was kept for this RCT. So 26 hospitals in 9 countries. Now they recruited 379 patients, mostly E. coli and Klebsiella. And the primary outcome was 30-day mortality. And unfortunately, the mortality was much higher in the piperacillin tazobactam arm compared to the meropenem arm, and it did not satisfy their criteria for non-inferiority. Now, the validity of these trial results, they have been repeatedly analyzed and looked into, and looks like a very robust trial with clear clinical endpoint showing that it is actually true. So the summary of this trial is that if you have a serious gram-negative ceftriaxone resistant bacteremia, you should avoid BLBLIs like piperacillin tazobactam. Now, why did piperacillin tazobactam fail is the most important question. So they went on to analyze that. That brought in so much insight into how resistance to piperacillin tazobactam is mediated. Now, this is their analysis of that. You would look at the piperacillin tazobactam MICs. Previously, up to 16 was considered susceptible, and now the revised CLSI breakpoints after 2022 would be 8. If you look at that, I want you to focus on the gray bars. They suggest that there is a OXA1 plus a ESBL. And when that happens, usually it is oxacelinase 1. The MIC for piperacillin tazobactam is often higher, and it is also clear that AMSPs may have false positive susceptibilities, especially when tested via rapid testing methods for piperacillin tazobactam. So the main reason why this trial failed could be it's truly that BLBLIs are inferior. The other possibility may be that many patients, if you look at the current criteria, we would have called all these patients as resistant. And when they reanalyzed the results, they showed that this is the group more than or equal to 16, which primarily drove the poor outcome in this trial. And this is, of course, there are multiple meta-analysis in this region, and I have put the most recent meta-analysis. It shows that whether if you use it for empirical therapy or for definitive therapy, the outcomes between BLBLIs and carbapenems are not different. So this is the summary of what we have now. There is one trial that shows that piperacillin tazobactam is inferior, and multiple meta-analysis predominantly from the trial as well as observational data showing that there is no difference. Now, I want to clearly state this. When I talk about futuristically BLBLIs, I am not talking about piperacillin tazobactam, because be it piperacillin tazobactam or to some extent cefiperazone sulbactam have significant problems in the Indian context if we do it as a carbapenem-sparing strategy. So this is the JMI Sentry surveillance data with more than 55,736 E. coli and Klebsiella isolates, showing that the distribution of MICs for piperacillin tazobactam, you would see that the most agreed upon epidemiological cutoff value is somewhere around here. So most of the piperacillin tazobactam isolates we used to call as susceptible. For example, here would be resistant currently. So the cutoffs has changed, that is one. And this has resulted in somewhere between only 50 to 60% of our ESBL E. coli will be piperacillin tazobactam susceptible. Now, the second point is it is very difficult to measure piperacillin tazobactam susceptibility, especially if OXA1 is present. If you look at Indian data, about 60% of our isolates have OXA1. And we don't do a PCR to look for our OXA1. So commonly people would say if you look at amoxicillin clavulanate susceptibility. So if you have both amoxicillin and clavulanate and piperacillin tazobactam higher range MICs, then you are very likely dealing with a OXA1. So that's again something that is a bit tricky, especially if you rely on a Vitek and things like that. The third thing is that it's very clear that OXA1 is common, and piperacillin tazobactam has very inconsistent activity against AMSPs, OXA1 and OXA30. Also, there is a group where there is increased production of ESBL, where piperacillin tazobactam will not perform very well. So putting all this together, in addition, the tazobactam dose that is used in piperacillin tazobactam is not enough to inhibit many of the ESBLs as well. All this together, we can conclude that piperacillin tazobactam may not be the ideal carbapenem-sparer. Now, once we decide that, we come to what are the new BLBLIs we should be interested in. So I am particularly interested in the Indian context in two drugs. One is you have cefepime high-dose tazobactam. So you have cefepime as a molecule which is stable against AMSPs as well. And you have cefepime and high-dose tazobactam, which could be a very good agent against ESBLs, AMSPs, and OXA1 producers. So if you look at this data, it showed that among 23,246 isolates, there is very high susceptibility for this molecule. Now, if you look at our own Indian isolates, this has been tested in CMC as well. In our lab, you can see that the susceptibilities for cefepime N-metazobactam is 100% parallel to, very comparable to meropenem. And you can note that this is same whether you have an OXA1 or an AMSP. Be it Klebsiella pneumoniae, E. coli, both of them with all the resistance mechanisms we are interested in, this drug is very good. And the next molecule is cefepime-tazobactam. If you look at the distribution of MICs for cefepime high-dose tazobactam, you can see that most of the isolates have very low MICs. This is in comparison with other options, as you can see, showing relatively higher MICs, and this could be a very promising molecule in the Indian context. Oh, there's only one trial, unfortunately, in this, and that did not compare against meropenem. It compared against piperacillin-tazobactam. It was done by Professor Keitke's group looking at complicated UTIs, and they asked two questions: whether there is clinical and microbiological cure, and also both clinical and microbiological cure in these patients. And it looked like cefepime enmetazobactam initially satisfied non-inferiority, and then they went on to analyze superiority, showing that cefepime enmetazobactam is not only non-inferior but superior to piperacillin-tazobactam. So this molecule is quite promising, currently available in the Indian setting. The other one we would be very interested to have would be cefepime-tazobactam. Now, this is a point that all of us would agree that if you use a BLBLI as a carbapenem sparer, there is a hope to dent the burden of carbapenem resistance in the Indian setting. This is a figure I'm sure many of you are familiar, but I want to make one point. The largest driver for AMR is human antimicrobial use. And when I say human antimicrobial use, we must realize that if you take carbapenem use predominantly drives carbapenem resistance. It doesn't mean that it doesn't drive other resistance. In a similar fashion, BLBLI use is associated with significant risk of BLBLI resistance. There is increased risk of carbapenem resistance as well. But if you look at it numerically, it appears as though from separate studies, the risk would be predominantly for the parent antibiotic to which the particular person is exposed to. So, and there have been many studies which have clearly shown that to decrease carbapenem resistance, you need to avoid using carbapenem. So that's again an indirect evidence showing that if you move to a strategy that is carbapenem-sparing, you probably would be able to bring down the burden of carbapenem resistance. This is a data from London in University Hospital showing that once they brought down the meropenem exposure inside the hospital, the rate of OXA48 infection significantly came down. Now, so it appears as though if you prefer a carbapenem-sparing option, you would be able to bring down the risk of carbapenem resistance, but there will be a lot of players in it. It's not such a simple question to answer. There will be basal resistance, hospital factors, especially infection control, and LMIC versus upper and middle income countries. They may have a different play, but this is the basic concept I want to touch upon. Now, the last bit is what additional caveats do we need to use BLBLIs as carbapenem sparers. Now, it's very clear when somebody is very sick in day 1 and to day 3, we don't have diagnostics at that time usually, and our diagnostics would start becoming available here. And if you suspect ESBL producing infection, your treatment of choice should be a carbapenem after the Moreno trial. But then where can we consider BLBLIs that are currently available widely, like piperacillin-tazobactam, less severe source like urinary source, biliary source, not in shock, not unstable, fewer comorbidities, not immunosuppressed, and you have a piperacillin-tazobactam susceptibility. So it's probably more apt to use them as a definitive therapy setting currently. So that's all I have to say. I'll just wind up with the currently available agents. I'm talking predominantly about the BLBLIs like piperacillin tazobactam, cephalosporin sulbactam. I'm not talking about BLBLIs like ceftazidime avibactam or meropenem vibobactam, which are reserved for carbapenem resistance. In that situation, role of BLBLIs are restricted to less sick, non-bacteriemic infections with documented susceptibility. But in future, we are terribly excited about two molecules, cefepime enmetazobactam and cefepime high-dose tazobactam, because they would turn off three things we are interested in the Indian situation. One is OXA1 and ESBLs and also AMSPs. So we want to see some data comparing with meropenem. If that's available, it would be wonderful. Thank you so much. I'll hand over to Akshata. Yeah.
Thank you, sir. I think you've taken up all my points as well. So let me try to speak. It's difficult to speak against this topic because I think as an ID, we do agree that it is necessary. But yes, let's talk about carbapenem, whether carbapenem-sparing strategies. Is it a futile effort? So I will start with a case. So we have a 43-year-old male with coming to us with fever, chills, burning, micturition, flank pain, definitely complicated pyelonephritis. His inflammatory markers are high, procal is high. USG suggests bilateral pyelonephritis, urine and blood culture grows E. coli, which is ESBL. So syndrome is urosepsis, pyelonephritis, ESBL, E. coli. He was given peptides for 14 days. And this is not a made-up case. It is a case which we have experienced, and we have had multiple similar cases as well. So after 2 weeks, he comes to the emergency again with fever, now in altered mental status and in hypotension. So currently in shock. So what happened here? So was it a relapse of the UTI or the ESBL UTI? Was it a new infection? Was it so he was treated for 14 days. So was it a wrong duration of antibiotics? So pyelonephritis, we do have data saying that 7 days is sufficient. Was it a wrong initial choice of antibiotic? Patient was treated with peptides because there was demonstrated susceptibility to peptides and resistance to the ceftriaxone. Whether source control was not done, or whether was there any other source. So there was no evidence of abscess. So definitely source control, there couldn't be any source control which could have been done. Other thing is bilateral pyelonephritis. Maybe you have to rule out endocarditis. We don't know. So that again echo was normal. So why do we need, I will start the talk with why do we need carbapenem? So it is one of the wonderful drug which has quite broad spectrum coverage, and we do have increased community acquired ESBLs, and it has been given as a drug of choice, and definitely as it will be used as an empiric choice in complicated infections, severe infections, and in immunocompromised hosts. So we have a good saying that hit hard, hit fast, and hit often. So when a patient is acutely ill and the empiric choice where you need to hit it fast. So definitely, again, carbapenem is the drug of choice. So the risk of inadequate empirical coverage often outweighs the theoretical benefit of sparing the carbapenem. This is the ICMR 2024 report of the susceptibility of E. coli and Klebsiella. So if you can see, almost this is the susceptibility data. So almost 80% of the strains, this is the blood sample. So of almost 80% of the strains are ESBL. So as sir has already spoken, most of our GNBs concomitantly produce ESBL as well as AMSP, and so again, so these ESBLs will have lower efficacy with the peptides, and also depending upon the severity of the infection, the inoculum effect. So that brings to my first point of argument, whether carbapenem sparing strategy, which I think sir has intelligently excluded, is the older BLBLIs, that is the peptides, which even the current guidelines, the IDSA, ECMED guidelines or the guidance do not favor. So this is the Merino trial, which has been almost detailedly explained by Dr. Abhimanyu sir. So Merino trial demonstrated that peptides, there was higher mortality. I mean, basically, it was not inferior. It was the non-inferiority was not met. So again, there has been many post-hoc analysis of the Merino. Still, they do recommend peptides should be avoided for bloodstream infection caused by ceftriaxone non-susceptible E. coli and Klebsiella, especially if the MICs are higher, because that's when you start seeing OXA ones. So, and so that was about the peptides, but there are other alternatives, right? So why not use the other alternatives? But again, there is limited efficacy with the alternatives. So in an attempt to spare, we should not be suboptimally treating, which can lead to worse outcome. And again, coming to the spectrum, none of the alternatives will match the spectrum of that of the carbapenem. So most of these will be required to be given as a combination therapy. So we have the fluoroquinolone, which has excellent spectrum, but in India, unfortunately, most of them, I would say more than 90% are resistant. Then we have the cefepime, which is supposed to work, but then this can work if the MIC is less than 2, and in higher doses, but again, it is associated with higher mortality. Then we do have the newer BLBLI, that is the ceftazidime, avibactam, and others, but these should be reserved for the CRE infections. Then we have the aminoglycosides. They do have some role, especially in UTI, but most often in the sepsis, you cannot give it as a monotherapy, and most often the patients will be having AKI. So again, the dosing of the aminoglycosides or use becomes tricky. Phosphomycin, yes, definitely in UTIs it can be used, and even IV phosphomycin has been used in few of the trials. Forest trial showed us it could be used, but it's more often restricted to the urinary tract infection. TG cycline definitely not in bloodstream infection or UTI or in the patient in sepsis, and definitely not as a monotherapy. And it also attains very low levels in the ELF and has high volume of distribution. Nitrofurantoin and Cotrim, again, nitrofurantoin definitely restricted to the lower UTI, and Cotrim can be used as a step down and not as a therapy per se. And regarding the other newer BLBLI, I think I'll be talking about that, the cefepime tazobactam and cefepime enmetazobactam I'll be addressing in the rebuttal. Then whether the carbapenem sparing strategy the giving the carbapenem is leading to the resistance. Again, the resistance evolution is unpredictable. So if you remember the story of penicillin, there was resistance even, I mean, before the penicillin was introduced. So there's always the genes which can be there. And why did the ESBL evolve is by the use of cephalosporins. Also the carbapenem resistance is already widespread, and so any antibiotic you're going to introduce, you're irrespective of you abusing or misusing, the resistance is a shadow which follows, and they can also spread independent of the carbapenem use. And definitely, so it's not necessary that you give carbapenem only, then there will be resistance developing. So they can be cross resistance because most of these are mediated by the plasmids. So do we have data? So this is a study impact of prolonged carbapenem use, focused antimicrobial stewardship on antimicrobial consumption. So here again, they looked at the pre and post intervention. So basically they did feedback, post-prescription feedback audit. So here they have looked at the resistance pattern where you can see pre-intervention and post-intervention. There was no difference in the resistance. Then again, whether the clinical reality versus theoretical stewardship, because most of these hospitals will lack the real-time diagnostic leading to the empirical use of carbapenem, and also we don't have really the local specific antimicrobial data to empirical devise local guidelines. So this is ideally if you have rapid ID and AST and other rapid this one. So this could shorten the time, or you can shift the patient on a carbapenem-sparing strategy, which most often is not available. Next is the economic and operational challenges. There is limited availability of the novel alternatives, including the cefepime enmetazobactam, which is spoken, and also most of these will require higher costs and a longer hospital stay. And as I mentioned, the spectrum is not adequate, so sometimes we may have to give the combination. therapy, which will lead to polypharmacy. And where is the proof for the collateral resistance development? So this is the recent carbapenem stewardship with ertapenem and antimicrobial resistance, where they looked at various studies which they have done the stewardship for restricting the carbapenem. They have seen most of these studies have seen that carbapenem resistance did not increase. The carbapenem usage did not increase the carbapenem resistance in the Enterobacteriaceae. There was some increase in the Acinetobacter and as well as Pseudomonas, basically when they use the ertapenem. And this is another study which was done in Japan, evaluation of the carbapenem antimicrobial stewardship. It was a prospective audit and feedback. So here again, they have seen that before and after the intervention, there was not much difference or statistically significant difference in the resistance pattern. So this one, again, this was the most 2020 study, multidisciplinary antimicrobial stewardship intervention focusing on carbapenem de-escalation. Here again, there was pre and post intervention. There was no difference in the meropenem resistance. And the carbapenem resistance is not driven by only the use of carbapenem. There are studies which indicate that you'll have to concentrate more on the other aspects, including poor infection control practices, and just focusing solely on antibiotic choice may not be effective in reducing the carbapenem resistance. So what actually requires to be done is a focused, complete stewardship where you have multiple measures rather than just restricting the use of the carbapenem. So summarizing, so we do have increasing community acquired ESBL, and for the broad spectrum coverage of the organism, and as a user in empirical situation in severe infection, and because we are having limited efficacy of the alternatives, and as we have seen, the resistance evolution is also unpredictable, and also due to the economic and operational challenges, and not much of data regarding the collateral resistance development. I would say that just restricting the carbapenem use is going to be a futile effort in the stewardship. Thank you.
What happens next, Akshata?
Sir, any rebuttal you would like to argue against any points against my talk?
Yeah, so I want to give 2 points. One is that I feel you would have realized that for the clinical indications of use, me and Akshata agree 100%. That we both feel that for the initial severe high-risk infections, we should not be considering BLBLIs. And piperacillin tazobactam has a lot of issues. She also mentioned that she would talk about the newer BLBLIs in the rebuttal. One point I just wanted to address was the issue of resistance development on exposure. Now, resistance develops universally, and the rate of resistance increases when there is an antibiotic pressure. And when you use a specific antibiotic, for example, especially a broad spectrum antibiotic, there are few things that drive resistance development to that particular antibiotic. One is whether you have an already present carbapenem resistant clone in the abdomen already existent. That is one. The second thing we often don't think about is the enterohepatic circulation. If your drug has a lot of enterohepatic circulation, your chance of resistance development really goes up. And if you look at the odds of developing resistance in relation to BLBLI versus carbapenem, that is where the risk of carbapenem resistant appears to be high. But I agree in the sense that we don't have head-to-head nice data showing that BLBLI it's this much and carbapenem exposure it's this much. It's just a presumption that maybe it will be higher. And any AMSP needs two things. One is it needs good diagnostics, and it should have at least 2-3 drugs in the armamentarium. Then only AMSP would work. Currently, we don't have that with the available BLBLIs. If the newer ones come up, then we would have a wonderful option of having few drugs plus also good diagnostics can make a difference. Thank you. Yeah.
Okay. There's some issue. Yes, sir. So I definitely agree with that point. Yes. So there are, I mean, very few points which I would like to address and rebut. So one thing, as you had spoken regarding the newer antimicrobials like the cefepime enmetazobactam and the cefepime tazobactam. As the study, we have very limited studies which are available, and mostly they are concentrated on urinary tract infections. So we don't know how they will actually perform in other infections. So that is one thing. And obviously the availability becomes an issue, and again as the resistance definitely follows, so these BLBLIs are more prone to the beta lactamases. So I would say that these 3 points. And regarding the resistance, yes, I think there was one of the first papers to correlate or what okay, I'm sharing the wrong slides, sorry. Where is this? Okay, there is some issue. So I would say one of the first studies which looked at whether the resistance, association of the resistance, I mean, use of carbapenem and the resistance was published in ASM. So they looked at, most of these studies just look, what did they look at is, they have looked at the consumption of carbapenem, and they have looked at the number of gram negative bacteria which has carbapenem resistance. I would say that is one of the drawbacks, because they have not addressed the other factors, including the infection control practices, environmental, how many of them are environmental samples and how many of them are actually colonized rather than the infection perspective. So yes, sir, these are the points which I wanted to mention regarding this in the rebuttal. There is some issue, I'm not able to move. Yes, sir. I'm not able to share the slide, so it's okay. So, is there any end thoughts you would like to have? Any last thoughts about this? Yes.
Yeah,
So
thank you, Akshat, for the
yes,
opportunity.
thank you, sir. So I think we all agree that carbapenem, I think most of the summarizing has been already done by the sir initially itself. So we do agree carbapenem is a drug which we need to give when the patient is having severe infection, sepsis, and we don't know the source of infection for the broad spectrum, but we need to narrow it down as soon as possible, as feasible for about the regarding the patient status. Thank you, sir. With that, next topic. So I think there are many people who have joined now. So for them, I will be again mentioning regarding the usage of the VVox or polling platform. So next talk, I'll just introduce and then I will be sharing about the polling. So next talk is tackling challenges in community versus nursing antimicrobial stewardship. We have with us 2 eminent speakers. Dr. Sagar Kadanga sir, who is associate professor in Department of Medicine in AIMS Bhopal, and we have Dr. Sanjay Bhattacharya sir, who is a senior consultant and HOD in microbiology at Tata Medical Center, Kolkata. Over to you, Dr. Sagar sir and Dr. Sanjay sir, for your talk. So first we will have the polling, sir, both of you. So for those who have joined newly, so if to join this poll, you can just type in vvox.app and enter the code which is there on top. That is so that you please enter the code, then you will be joining the poll. So, and then once you join the poll, you can just click on whatever you feel you are supporting. So, which aspect of the antimicrobial stewardship do you find it more challenging? The community, the nursing, antimicrobial stewardship, both are equally challenging, and neither I have other concerns. So, let's see the poll. I think few of them have joined now.
Akshata, you can share the
Sir?
you can share the Vivox scan code so that people, newly joined people, might scan it.
Okay. Okay, sir. Again, I will just share.
Just share that scan code.
Yes, sir. So we have sir, equal response for like both of you. So over to you, sir.
Thank you. Let me try to. Is it seen?
Yes, sir. Yes, sir.
Thank you. Community antimicrobial stewardship needs some sort of deliberation. It's challenging. At the same time, probably a new horizon in the war in AMR. If you look at various literature of community antimicrobial stewardship, it mentions basically it is targeted at the community and honestly by the community.
Sir, just a minute, sir. So your slides are not moving, sir. So could you put on slideshow and then?
I have already put on slides. So would you mind sharing my?
Sure,
my
sir.
slide?
Yes, sir.
Okay, then I am stopping mine.
Sure. Sir.
Thank you. So by the time she is loading the slides, community antimicrobial stewardship, if you look at the literature says it should be done at the community and preferably by the community itself, or to be less specific, by the healthcare workers. So if it is done by the community, probably it will be the best option. I mean, by the community mean all the people in the community, let them be the healthcare workers, the veterinary, the school-going children, the municipality corporation workers. So all should have an equal responsibility to deal with the community antimicrobial stewardship. Next slide.
Yes, sir.
So all of us are aware of these strategic priorities that has been given by WHO. From 1 to 5 has been given by the Global Action Plan, GAP AMR by WHO. And the 6th one is the leadership, the importance of the intersectoral collaboration and leadership roles that has been emphasized by the National Action Plan of India. So I would like to pitch in the 6th leadership and intersectoral collaboration point to be highlighted at this point of time, which is of utmost importance when we will be dealing with the community level antimicrobial stewardship. If you look at strategy priorities 1 to 5, they were basically designed for in healthcare facility setup, awareness and understanding among the healthcare workers, knowledge and evidence gain, lab and surveillance, all these should be done by the healthcare workers or by the hospitals. But at the end of the day, when we are talking about the community antimicrobial stewardship, there has to be some activity by the community and for the community level. Next slide, please.
Sir, I have shared the slide control to you, sir. You can change it.
Okay. No, it is not changing. You can change it for me. Yeah, this is a popular slide by WHO. The antimicrobial resistance, most importantly, spreads by the food chain, either vegetarian or non-vegetarian food, to the environment, and ultimately it goes on circulating in the community. That is why we see a lot of community pneumonia, UTI, and abdominal infections, which are truly multi-drug resistant. Next slide, please. So now moving into next slide, Akshatha. So if you look at the various strategies to mitigate the AMR challenges in the hospital, basically there are three pillars. One are the antimicrobial stewardship practices by the clinician, the diagnostic stewardship practices by the lab department, and IPC, the overall interpectoral or the nursing antimicrobial stewardship practices like various infection prevention control practices. So all these activities are done at the hospital, but are they really fruitful for the level of community? Next slide, please. So last slide, last. So if these three pillars were primary importance at the level of healthcare delivery setup, like hospitals, truly they are of least importance at the level of a community. If I am looking into my state, Madhya Pradesh is one of the largest state of India with 52 districts, and in 50 districts we do not even have a microbiology. So to try for a diagnostic stewardship, it is non-existent. Antimicrobial stewardship to be practiced by the physicians without diagnostic stewardship, futile. So mostly we deal with infection prevention control practices by the district hospital or the primary and secondary healthcare center nursing staff. Next slide. So when you look at the literature, this tricky new entrant into the antimicrobial stewardship domain many times are used synonymous with misuse of antibiotic at the community by the pharmacy, like the over-the-counter availability of freely available antibiotic in India and the LMIC countries, misuse like drug sharing by the family members and attenders of the patients, and there are plenty of issues with the disposal policies of the remained antibiotic in home or in the community. However, if we look at the community antimicrobial stewardship overall, it is beyond human health. Antibiotics are being used in environment, agriculture, veterinary sector, poultry sector, and all. So it has to be multifaceted and multiple stakeholders. Next slide, please. So who are the real stakeholders when we talk about the community antimicrobial stewardship? Obviously, the healthcare providers, be the human or non-human veterinary healthcare providers, are the torch bearers, but they can only assist the others. Truly, the community personnel, I mean the whole of the community, whether they are environmentalists, agriculturists, industries, pollution control board, Food and Drug Administration, school and higher education, all of them has to come together. As you know, all these are different sectors. We, at this point of time, we do not know what exactly we should be doing at the level of the community. Next. As they are multi-sectoral, so the approach has to be multifaceted and multi-pronged. Probably the most important strategy will be information, education, and various communication strategies. What is AMR? If you can go and ask your father or mother, what do you mean by antimicrobial resistance or antibiotic resistance? When I tried last time with my mom, who is a 70-year-old lady, she tells antibiotics are all good. Why not to take them? Or what harm can antibiotic can cause to you? So probably at this point of time, we are unable to make an impression in the community that antibiotics are still some type of a poison. We need that much of poison to kill the organism than to kill us. So there has to be a behavioral advocacy at large scale. Mass media influence has to come into the picture. Regulation, many studies have advocated that pharmacies should be banned in prescribing certain set of antibiotics. Government of India has a Schedule H1 and H2 drugs. We all know the status of Schedule H1. Even with these regulations, many antibiotics even are available in the open market. So I don't think only by the regulation, the availability of the antibiotic at the community will be decreased. Next slide, please. If you look at the basic pioneers of AMR campaign, the Global Action Plan by WHO and the National Action Plan on AMR, they are completely silent, at least for a decade. And they do not mention anything about the process, how to do it, and what are the outcome variables, what are the outcome indicators, how to measure the community AMSP program. We do not know it. Next slide, please. Lately, over last couple of years, the WHO has come up with some patient charters, those who are discharged from the hospital. They are supposed to be our advocates in the community, probably making awareness more easily to their surrounding. I will be coming to that slide in my next slide. At this juncture of time, last slide, please. I would like to give you an impression. There is a concept of, this is my concept. This is, I call it as the inverse and the erect pyramid of community antimicrobial stewardship. At this point of time, the campaign of AMR is broadly based on making the guidelines, how the IPC will be done, what is the syndromic guideline for prescribing antibiotic, whether we should use Carbapenem-sparing agents or BLBLI. So we are in the process of making guidelines, but truly speaking, for community antimicrobial stewardship, it is completely inverted of that. We have to make or educate, train the clinicians and the community participants as a whole, which is important for us, that at least there is antibiotic is not like any other drug. It is not paracetamol. You can't go and purchase antibiotic like that. Then there will be some importance of the infrastructure development and back-end support. If at the level of the community, if somebody is sitting in the primary healthcare and you are telling them that you should not write meropenem or BLBLI, then what else he or she will write when the patient is sick enough? So there has to be a back-end support by the tertiary care centers. Audit and feedback, formulary restrictions will work, but to very limited extent. Guidelines, actually, there are no guidelines for the community level antimicrobial stewardship, what to be done, how to measure, and how to measure the outcome. Next slide, please. Lately, the European region of WHO has framed out various strategies. The nomenclature is as BCI, Behavioral and Cultural Insight for Health for Mitigating AMR. This is a about 50-page document. If you go through those documents, again, it's more so elaborative, but there are no foolproof process guidelines and measurement outcome guidelines. How do we move ahead with measuring how to, if a particular process is really fruitful or not. Next slide, please. This is again an exciting model that I would like to propose, and it's already a published article of me only. Community antimicrobial stewardship has to be a business model. We are still struggling for the AMR campaign in healthcare facilities. If you are not working in a probably tertiary care setup where high-end culture facilities are available, AMR doesn't bother much to us. But in community, overall, the antibiotics, the proportion of antibiotics are used to the maximum in community, either by non-human healthcare providers or various other industries like pharma industries, alternative healers, the quacks, the agriculture industry. So at this point of time, we have to develop some sort of advocacy to create a demand for the AMR awareness in the community. We know that when there is no demand, how much you supply, the supply will fade away one day. So at this juncture of time, I would like to give you impression that at this point of time, the community has got absolutely no demand for the AMR campaign. Community, I mean, go and ask your students, go and ask your parents, your kids, your near and dears who are not in the healthcare industry. What do they mean by AMR campaign? When did you last see a AMR related advertisement in your TV, in your social media handling? If you are not a healthcare worker, I don't think you would have seen it. So let's create a demand first, and probably you try to supply what we have to supply for community level antimicrobial stewardship practices. Last slide. Yeah, all these are my references. Most of the slides have been taken from the WHO earlier. With this, I rest my case. Over to you, Akshatha.
Yes, sir. Thank you, sir. So we'll have next Dr. Sanjay Bhattacharya, sir, speaking about the challenges in nursing stewardship.
So, good evening. Am I audible?
Yes, sir. Yes, sir.
So can you just allow me to share the slides?
Yes, sir. You can share now. I stopped sharing.
Okay. So,
Yes, sir. It's visible.
okay.
Could you put it on slideshow, sir?
Trying to do that. Is it visible
Yes,
at the
sir.
slideshow?
Yes, sir. Yes, sir. Perfect.
Okay. So thank you, Dr. Akshatha, for having me here in this forum. And I'm going to speak about nursing stewardship. Obviously, as you can see, that I do not work in the nursing domain, but through the activities of antimicrobial stewardship program, I have been closely associated with certain implementation strategies with regard to antimicrobial stewardship program. And I would like to take you through my experience in antimicrobial stewardship with regard to what I have seen at the ground level. So if you see this particular slide, what you would realize is the fact that there are actually two domains which are sort of working in parallel. For antimicrobial stewardship, you need a hospital antibiogram, and you need an antimicrobial policy. Obviously, following that, you need a triad of stewardship, which includes antimicrobial stewardship, diagnostic stewardship, and infection prevention and control. Followed by that, you need some audits, which would have a component to assess the structure, the process, and the outcome. And then you have some implementation issues and implementation challenges for which you would actually be looking at a variety of different things, right from the start of order and indenting of antibiotics by the nursing team, maintaining ward stocks of antibiotics, securing IV access for the patient, keeping the consumables for the administration of the IV antibiotics, reconstitution of the antibiotics with the appropriate diluent, making sure that the concentration of the antibiotics in the dilution is right. Then you would administer it and then monitor the side effects and the adverse effects and monitor the clinical progress. Now, what happens is that the upper half of this particular slide, which is the half above these dotted lines, is essentially a domain which is dominated by doctors, the prescribers. And so the hospital antibiogram is put forward by the doctors, the antimicrobial policy, the stewardship activities, and the diagnostic stewardship, infection control, audit, everything is done by doctors. And the bottom half of this particular slide is dominated by nurses. But here lies the implementation issues. So I feel that there is a disconnect between the upper half and the bottom half of these two particular domains. We can call the upper half domain as a cloud land and the bottom half of the domain as the grassland. And there seems to be some sort of disconnect between the cloud lands at the upper part, which is dominated by the doctors, and the grassland, which is at the bottom half of the domain, which is dominated by the nurses. Now, what I'm saying and arguing for is there should be a better coordination between these two domains. The grasses would not be able to grow without the clouds raining, and the rains would be actually meaningless without the presence of the grass and the vitality of the grass. So that's my submission about this particular slide. Now, there are quite a few learned papers on this particular issue of antimicrobial stewardship activities for the nurses. So what are these papers actually suggesting? So I will take you through 3 or 4 papers. The first one was published in the American Journal of Infection Control in 2019. And as you can see, the title is Exploring Nurses' Role in Antibiotic Stewardship, a multi-site qualitative study of nurses and infection preventionists. Okay. And this study was actually published from the United States. And the authors were not just from the Department of Nursing. And that's why I have listed the different departments where the authors came from. Apart from the Department of Nursing, there were physicians from the Department of Medicine, physicians from the Department of Pediatrics, physicians from the Infection Prevention and Control. There was representatives from the Healthcare Quality Promotion and from the public health. So it was really a multi-sectoral paper which came out in a very important journal, American Journal of Infection Control, first published in 2018, and I think came up in the print format in 2019. Now, this paper, American Journal of Infection Control, what it does, it discusses the various challenges faced by the nurses in the implementation of antimicrobial stewardship. And it suggests certain solutions to the whole problem. Those challenges, I'm not listing the entire list of challenges. There are quite a few challenges. I've just taken a few of them which this paper has actually addressed. One is unaddressed knowledge gap. So we know that the knowledge of prescribing about antibiotics, its side effects, its efficacy, its pharmacokinetics, pharmacodynamics, which would be much more in case of doctors compared to the nurses. It's just because of the training and the domain of work that we are involved in. There is also a discomfort of the nurses with regard to questioning the prescriber orders. Okay, so the nurses feel do not feel empowered enough to have the courage to actually ask the prescriber, in this case, the doctor, that are you doing the right thing? And the third, I would say that there are already established players in the field, like the physician and the PharmD, that is the pharmacists, who are already there looking into the domain of stewardship. And this leads to a syndrome called, who are you to tell me? So who are you to tell me is a symptomatic of a wider syndrome which affects some healthcare professionals. So, and the strategies which has been suggested by this paper include providing nurses with formalized training, education, and resources which will help them to understand the issues of antibiotic prescribing and antibiotic stewardship much better. Empower the nurses. I will come to this question of empowering a little later, and provide information on guidelines that specifies standard practices with regard to when to take the culture, when not to take the culture, when to use antibiotics, when not to use antibiotics, when to escalate, when to not to escalate or de-escalate regarding the treatment duration. Now, this empowerment of the nurses, it's not really a scientific issue, it's a cultural issue. Okay, so you cannot actually break the code of this by studying physics, chemistry, mathematics, computer science. You have to get into psychology, you have to get into sociology, you have to understand the economic, the dynamics of economics that play between the domain of the nursing field and the domain of the medical field. So it is only through the domain of humanities that you can understand, or we can understand as a group, the question of empowerment of the nurse. So it's a cultural issue rather than a scientific or technical issue. So the solution would lie in the humanities rather than in the domain of science. Now, what are the recommendations from this paper from American Journal of Infection Control? So this paper, which is very important, lists 5 recommendations. And it says that the nurses can play a major role in antimicrobial stewardship. Number 1, by questioning the medical necessity of unnecessary cultures or not sending cultures when clinically indicated. So I will give you 2 examples. So the patient is escalated in antibiotics are escalated in a febrile patient without blood. Now, this does happen very often. So escalation is done without actually sending the relevant cultures. And that leads to more empirical treatment and less evidence-based. The second is the other situation where the physician sends cultures on everything, even when it is clinically not indicated. So you have a patient with pneumonia who is developing a sepsis. You know there is a respiratory tract infection, but you say that you send blood cultures, sputum cultures, or bronchoalveolar lavage cultures, but you send also a urine culture in a catheterized patient, which probably would yield nothing, or at the most it will deal colonizers, and you will be distracted by those culture results and lead to unnecessary investigations. And you may run out of money when actually a proper urine culture is required. There is also the recommendation of ensuring proper techniques when collecting a culture, because cultures are taken essentially by nurses. So sending blood cultures in requisite volume, one from the peripheral site, another from the central line site, obtaining and ordering and recording an accurate drug allergy history. So very many times it is a nursing team which actually records the first history of allergy. Encouraging the prompt transition from IV to oral antibiotics. So this can be a prompt from the nurses to the doctors. The doctor can consider changing the IV antibiotics to the oral antibiotics because the patient seems to be doing quite well and able to tolerate medicines. And we have a sensitive antibiotics to which the patient was not allergic. And in initiating an antibiotic timeout. So sometimes we go on giving antibiotics, there is no clinical response, the patient is stable, but there is maybe a fever, a one-off. So is it not time to actually say that can the antibiotic be stopped, given a gap of 2 days when the patient is clinically stable, reculture, and then consider restart with something else? Now, these sort of prompts can be provided by the nurses at the bedside, but for that, you need to empower the nurses. So the second article is from the International Journal of Nursing. Now, this paper came from Australia, and it was published in May 2021. And you can see the title of the paper as Nurse Role and Contribution to Antimicrobial Stewardship, an integrative review. Okay. It seems Australia and Australian nurses has done a lot of work with regard to antimicrobial stewardship and its role in the nursing community. And this is one of the papers which highlights this particular point. So what does this paper actually say? So it says that the formal inclusion of nurses in antimicrobial stewardship has been associated with improved nurse knowledge, nurse confidence, and in some cases, improved clinical outcomes for patients. So there is no doubt that it would improve the knowledge of the nurses when you integrate them, engage them in antimicrobial stewardship program. You would also increase the confidence of the nurse if you engage them in stewardship program. Now, with regard to the third assertion that the clinical outcome of the patients would also be improved, there is only very limited evidence at the moment. I have not gone into the details of the original studies, which has looked into the clinical outcome of patients because of nursing involvement in antimicrobial stewardship program. But that would be something of a research area. So we need to develop studies and do studies in this particular domain, that how involvement of the nurses can actually improve clinical outcome of patients in antimicrobial stewardship program. So from the International Journal of Nursing Studies, which was from May 2021, it highlighted that there are certain things which are enablers of nursing engagement in AMSP. So certain things which facilitate engagement of the nurses in antimicrobial stewardship program. So we need to focus on the role of nurses in patient advocacy. So the nurses could be the advocates of the patient. The nurses can put forward the point of view of the patient more eloquently, more with greater clarity, with greater articulation to the doctors. There could be also improve the nursing education. So if you improve the education of the nurses, it would be an enabler for antimicrobial stewardship program. There could also be design interventions to reflect nursing workflow and practice. So if you actually, so we do a lot of interventional studies, but our interventional studies for AMSP are not always geared towards addressing the concerns of the nurse, the challenges faced by the nurses at the battlefield. And engaging nursing leadership is very critical because it is they who would actually implement, monitor, train the nurses at the ground level and developing a supportive workplace culture. So these are the essentials, requirements or enablers for involvement of the nurses in the AMSP. I emphasize once again that this supportive workplace culture is a cultural issue. It's not a technical issue. It's not a scientific issue. It is an issue of the mind. It is an issue of the human culture. Okay. So these are some of the, we go on to the next paper, which is a very important paper. And this paper is from the journal Clinical Infectious Disease, January 2016. Now, this paper, as you know, clinical infectious disease needs no introduction. This paper is actually from a group from Massachusetts, USA. One of the contributors are from the Mass General Hospital. And in this study, which has been quoted 260 times in Google Scholar and 182 citations in ResearchGate, it gives a very important thing. Understand about the role of nurses in antimicrobial stewardship. So the critical role of staff nurse in antimicrobial stewardship program, unrecognized, but already there. So they are saying once again that it is already there. So if you look at what are the functions within the AMSP model where all the healthcare workers are actually involved, okay, in some way or the other. So you have the patient admission domain, you have the patient safety and quality monitoring domain, you have the clinical progress domain, patient education and discharge along with it, and you have the 24-hour progress monitoring domain. And within each of these domains, there are so many subdomains like triage isolation, allergy history taking, timely and appropriate cultures, timely antibiotic initiation, preventing medication errors, monitoring progress and reporting it, preliminary microbiology results and acting on it in terms of antibiotic adjustment, antibiotic dosing, de-escalation, adverse event reporting, monitoring changes in clinical condition, antibiotic adjustment based on final cultures, and managing MDR and XDR infection through infection control or other measures. Clinical progress and patient education domain, you have IV to oral switch, OPAT, patient education, optimizing length of stay, long-term care, and you have readmission. So what you see, if you count all of these subdomains, you will get about 18 points. And if you add them up, you will see that these are a group of people in a hospital who are actually trying to implement AMSP and the patient treatment. So there is a nursing, microbiology, case management teams, which may include other departments like radiology, physiotherapy, whatnot, housekeeping, pharmacy, infectious disease, infection control, inpatient physicians, who are the ward doctors, and administration. And if you see that it is the nursing department, followed closely by the infectious disease department. Here the microbiology is quite remote because the microbiology here is a laboratory-based microbiology. In places where the infectious diseases department is not there, then either the physicians will take over or the clinical microbiologists, if they are sufficiently trained, they will take over. So although the nurses do the most of these 16 out of 18 points, they are not adequately represented in the decision-making process or in the strategy development process. So this is my last slide. And I would conclude by saying that the role of nurses is critical for antimicrobial stewardship. The nurses play a key role in implementation of AMSP. The nursing leadership need to be involved in the development of implementation strategies, no doubt about it. And it is time that the medical leadership work in close collaboration with the nursing leadership for AMSP. And last but not the least, without quality control and without appropriate nursing engagement, many AMSP steps would be compromised. And these would include things like ward stock maintenance of antimicrobial agents and other drugs, drug reconstitution, maintenance of aseptic techniques during preparation and administration of drugs, timely administration of medication, and monitoring and recording of side effects and adverse effects. Thank you very much for your time and patience.
Thank you, sir. I think nursing stewardship, involvement of nursing as well as a community is, least addressed. So, even antimicrobial stewardship as such is not implemented in most of the hospitals, but at least there is some, and because of the national AMR plan, so at least the few of the hospitals have started. But I think there is a lot of scope for this community as well as nursing, and in general, definitely nursing would have more effect, I feel, because after all, they spend the maximum time in the hospital and with the patient. So, any take-home points, Sagar sir and Sanjay sir?
Yeah,
would like to
I
add?
would like to bring to a point that, as we know, antibiotics in human health about 30-40%, non-human health about up to 60 to 70% of the time. So all these antibiotics are being consumed at the community. Community, I mean both the human, non-human, and at the same time environment. So if we are thinking about the community, how the community will be least exposed to the antibiotics, then the community has the right, at the same time we have the responsibility to make them aware. So it's a challenge how to make them aware to these school going children, start from school going children to the elderly people, and all those who are not involved in healthcare. So at this juncture of time, the AMR campaign doesn't address the community aspect of the antimicrobial stewardship, but it is no-brainer to think that it's a absolutely critical point to consider. I rest my case.
Thank you, sir. Sir, any take-home points, Sanjay sir, you would like to add?
I don't have much to add, but it would be good actually if programs that you are making with so much of effort and passion could actually reach out to the nurses. And as Dr. Sagar had said, even in the community, really involvement of the general practitioners in the community and the nursing leadership in the hospitals to implement AMSP at the domains where either the infectious disease physician or the clinical microbiologist are really not there.
Yes, sir, definitely. Thank you, sir. I would like to take this opportunity to thank both of you, Sagar sir and Sanjay sir, for making time and being a part of this. So, with that, we move to the next topic. So, next we have an interesting topic. So, pharmaceutical adversing plays a key role in public awareness, but does it cross the ethical boundaries? Does it promote the the responsible use of antimicrobials, or does it lead to overprescription? To talk on this, we have two eminent speakers. So, sorry. We have two speakers. Dr. Venkat Ramesh, sir is a consultant infectious diseases, Apollo Hospital, Hyderabad. And we have Dr. Prasanna Kumar, sir, assistant professor in the Department of Infectious Diseases, CMC, Vellore, with us. Over to you, Dr. Venkat, sir, and Prasanna, sir. So before that, we will have a poll. So for those who are not aware, so this poll, to join this poll, you need to scan this QR code or just type in vvox.app and enter this code so that you join this polling. So I'll just open the poll now. Okay, in case you're having any difficulty, you just have to type in this vvox.app and then enter this code 163440374. So we have some responses. Okay, just end the poll here. Okay. So over to Dr. Venkat and Dr. Prasanna sir. 100% response for over promotion. Yes.
Yeah. Can I share my 1 second?
Yes.
Yeah, one second. Let me just. Can you see my slides?
Yes, sir.
Yeah, and you can
Yes.
see it moving, right? Yeah.
Yes, yes, sir.
Okay. So, good evening, everyone. Thanks to Dr. Akshatha and Dr. Abdul Ghafoor, sir, for giving me this opportunity to be here and speak my thoughts. And my hope is that the two people who voted against pharmaceutical advertising will change their opinion. So the format is that I'll be speaking for 10 minutes and Dr. Prasanna Kumar then will speak for another 10 minutes, followed by 5 minutes of rebuttal. Okay, so I'm here today to tell you that pharmaceutical advertising promotes awareness and does not result in excessive promotion. I have no conflicting interests. I'll start with a brief story. So this is not the actual patient, but the patient was extremely similar. She had rhinoorbital cerebral mucormycosis and from a poor family and could not afford liposomal amphotericin B. So we tried giving her conventional amphotericin B, but she developed infusion reactions. Every time we gave her, it just didn't get better. Even with pre-medication, there was no resolution of her symptoms. She continued to have chills and rigors. She had extensive disease. Not giving her amphotericin was not an option. Posaconazole monotherapy, in a few patients post-COVID, we had used it, but it just seemed too risky in this case. And this was in the year 2023. So we were past COVID, and she had other risk factors, such as uncontrolled diabetes. So coincidentally, at around the same time, a pharmaceutical representative had come to me and had told me about amphotericin B emulsion. Okay, so lipid emulsion of amphotericin B was the product that I was made aware of. And then I looked at the literature, not much of data at all. Safety and efficacy of intralipid emulsions of amphotericin B. This is one paper published in Journal of Antimicrobial Chemotherapy in 1996. And as you can see here, only 37 patients received it. 30 were unevaluable, 2 failed, 1 improved, 4 were successfully treated. And then this was way back in 1996. They said that currently available data do not support recommendations for use of this formulation. And then there was another meta-analysis published in 2012. Lipid emulsion reduce ampho B. Does lipid emulsion reduce ampho B nephrotoxicity? This was published in SIDS. Systematic review and meta-analysis, and yes, there was some data that it reduced nephrotoxicity to the tune of about 18%. So something similar to liposomal amphotericin B. And I hadn't used a lot of this molecule during COVID. I was posted in another hospital where I didn't see much of post-COVID mucor. I saw a lot of COVID, but not post-COVID mucor. And most of the patients that I had seen were already on treatment. So my experience with this wasn't great. But I had this pharmaceutical representative talking to me about it, and I was a little curious. So, and he had mentioned two very prominent colleagues of mine, very senior ID physicians. And this is the actual email that I had sent Dr. Ghafoor regarding this molecule. So he said that due to non-availability of liposomal amphotericin B, he had started using lipid emulsion preparations as they were lower cost. In his experience, these worked well with good side effect profiles. And so did Dr. Priscilla. She said that there is less renal failure. She hadn't generated data. So I used it actually, and I had prescribed amphotericin B lipid emulsion. Patient tolerated it well. Of course, patient underwent surgical debridement and so on. clinically improved, and then the patient got discharged. So this is a case where, in a sense, pharmaceutical advertising led to increased awareness and consequently improved outcomes. So now the question remains as to what is the legislation surrounding pharmaceutical advertising. Okay, we are saying that it promotes excessive prescriptions, but is there any law governing it? Yes, there are laws. We have the Drugs and Magic Remedies Act 1954, called the DMR Act, which controls the advertising of drugs. The Drugs and Cosmetic Rules 1945, which regulates the labeling and branding of pharmaceutical products, cosmetics, and homeopathic medicines. And Indian Medical Council Regulations 2002, relating to ethical conduct that may affect the relationship of medical practitioners with the pharmaceutical industry. And please note this, because I'll be bringing this up later in my talk. The Uniform Code of Pharmaceutical Marketing Practices, that is the UCPMP code, self-regulatory code adopted by Indian pharmaceutical industry, and Code of Pharmaceutical Marketing Practices of the Organization of Pharmaceutical Producers of India. So yes, we do have a legislation for pharmaceutical advertising. Okay. Now, the Drugs and Magic Remedies Act 1954 stipulates that any advertisement of a drug that suggests or leads to use of a drug for diagnosis, cure, mitigation, treatment, etc. is prohibited in India. So if it is prohibited, how is it that pharmaceutical advertising exists? So there are exceptions, yes. One is a registered medical practitioner signboard. For example, you may say that you are infectious disease physician, you prescribe vaccines, treatment for HIV, tuberculosis, etc. So in a way, you are advertising the drugs, okay? And our pharmacology textbooks, or any textbook of infectious disease or internal medicine, Davidson, Harrison, Goodman and Gilman, so whatever it is. So treatise or a book dealing with diseases from a bona fide scientific standpoint. Then what we commonly see in our day-to-day practice, any advertisement sent confidentially to a registered medical practitioner. 3. And number 4 is any government advertisement or an advertisement by any government sanctioned person. So we saw this during COVID. The COVID vaccines were promoted. Some other treatments were also promoted by the government of India. So this is the exception to the rule where advertisement of drugs is prohibited. These are the exceptions. Okay. Now, direct to consumer advertising is considered illegal in many parts of the world. Only 2 countries have direct to consumer advertising. Those of you who have been to the United States, if you go there and you watch TV, you will find advertisements coming in. This is direct to consumer advertising. US and New Zealand are the only countries that have legalized DTCA. Now in India, DTCA is allowed for over-the-counter drugs. Okay, but we don't have a definition for what are over-the-counter drugs. We have defined what are prescription drugs. Anything that is not prescription becomes over-the-counter drugs. So DTCA is not allowed for drugs that fall under Schedule H and Schedule X. And drugs falling under Schedule G require the following compulsory warning. That is, it is dangerous to take this except under medical supervision. So just keep this in mind. Schedule X is our most common. Most of the drugs that we prescribe are Schedule H. Schedule X are, I'll show you those drugs. And Schedule G is a separate entity. So what are the over-the-counter drugs that we see advertisements for in India? It is most of these multivitamin pills. Okay, multivitamin pills. These are the ones which are promoted because these are available over the counter. Okay. Now some drugs are there under Schedule G. These should be taken under medical supervision, but are available over the counter. These are common cough syrups, for example. Okay. Then Schedule X are drugs which essentially neurotropic drugs. So methylphenidate, pentobarbital, secobarbital, methamphetamine, etc. Okay. Now we will look at this thing which was implemented in 12th of March 2024, that is the Uniform Code for Pharmaceutical Marketing Practices. Okay, and this was very strongly implemented by the Ministry of Chemicals and Fertilizers, Department of Pharmaceuticals, Government of India. All associations are requested to constitute an ethics committee for pharmaceutical marketing practices and set up a dedicated UCPMP portal on their website and take further necessary steps towards implementation of this code. Okay. So what does it say? That when the pharmaceutical companies are providing information and educational items, books, calendars, diaries, whatever it is, in healthcare settings, the value should not exceed ₹1,000 per item. Such items should not have an independent commercial value for healthcare professionals. Free samples, again, sample packs should be limited to prescribed dosage for not more than 3 patients for the required course of treatment. No company should offer more than 12 such sample packs per drug to any healthcare practitioner per year. Each sample pack should not be larger than the smallest pack present in the market. So if there are 10 drugs, it has to be only 10. It cannot be larger than the smallest. Okay. And please look at this. No gift should be allowed for personal benefit of any healthcare professional or family. Travel, pharmaceutical companies are allowed to sponsor travel, so to speak, only if the person is a speaker for a CME or a CPD program. Okay. So if you are going there as a delegate, you are not a speaker, the pharmaceutical company, as per the Indian law, cannot sponsor any kind of travel or hospitality. Monetary gains. Companies or their representatives should not pay cash or monetary grants to any healthcare professional or their family members under any pretext. Then coming to you conducted CMEs. Again, there are very well-defined regulations for these. One is it cannot be conducted in foreign locations. It only has to be conducted in certain medical colleges, professional association of doctors or specialists. Okay. And they are obligated to share the details of such events, including expenditures incurred thereupon, on their website. And these may be subjected to independent, random, or risk-based audit for this purpose. So please keep in mind, there is very strict checks and balances against promotion, especially over promotion. And with this, I will rest my case saying that I think it's often simple to believe that pharmaceutical advertising will lead to overprescription. But in reality, the checks and balances are there in the system, and we need to keep that in mind when we think about this topic. We live in a highly regulated society, tightly controlled by legal laws, and if not legal laws, there are very strict social protocols in place. Thank you.
Thank you, sir. Over to Dr. Prasanna, sir.
Thank you, Dr. Venkat. I think you have made my job easier. I thought you were voting and you voted for me when I saw you voting. So I will come to your points when I'm doing the rebuttal. But this is my outline here. We all understand antibiotic abuse drives AMR, and there could be multiple social determinants for the same. But I'm here to talk about what's the specific role of pharmaceutical marketing in driving unnecessary antibiotic consumption. Do they even promote qualitative prescribing? Something already dealt by Dr. Venkat, I will just touch upon it. So the problem is, if you look at, there are multifactorial. So not one specific going to increase antibiotic consumption. We all understand that, but we are here to discuss about promotional pressure and about advertising. These are also being accepted as one of the factors that contribute to antibiotic misuse. The problem is, it's not about against promotion. You see, these are two codes with the Dr. Venkat also alluded here. One is from the organizers, pharmaceutical organizers, when they say the definition is the promotion is promote the prescription recommendation. The same thing is done by the government, but it's the only point is it's still a voluntary, not mandatory, statutory. So it's not yet punitive. So government is still not can't punish anybody who violates this act, which thing. So, but the problem is the fine print is missing here. So the fine print is, do we somebody promotes here? Do they really give a balanced, up-to-date, verifiable, must not mislead either directly or by implication, and accurately reflect current knowledge and responsible opinion, and must be capable of substantiation, which must be provided without delay at request of the members of the medical and pharmacy professions. That's a fine print that would be missing from all of pharmaceutical marketing. They will say this drug will work. I do agree all that. That's good. But do they discuss the pros and cons of the drug, the merits, demerits, the side effects, what were they expected? Nobody, I think, discussed here. So look at this is antibiotic consumption over years in India, particularly over 10 years period, 11 to 19. As you can see, it's a relative different change of antibiotic consumption. You see, there is a drastic drop in access consumption and a rise in watch, and reserve is almost 250 times it has gone up. What do you think is forcing this? Because WHO now mandates all antibiotic consumption in the country, 60% should be from access group. Here we are seeing a reverse in Indian settings. Again, you see here antibiotics, cephalosporins, penicillins, antibiotic consumptions. You see the tetracycline, sulfonamides, aminoglycosides. These are very least used because nobody, the companies will not get any much margins in of these generic drugs. So nobody wants to promote these drugs. So not much used, I understand. They are all push the drugs which have the higher margin here. Again, as you can see here, we are one. Access is just 27% of the total consumption here. A watch is 54 and the reserve is 1% here. So coming to, this is the figure that will clearly tell you about the antibiotic consumption of different antibiotics. One is approved and unapproved. If you look at that deep blue, these are all unapproved drugs being consumed in India. So these are not approved by the Central Drug Standard Control Organization, but still we are using them the lot here. As you can see, cephalosporins, penicillins, macrolides, there are quite a lot of drugs which were unapproved still being used. Same holds good for FDC drugs. Much of the FDC drugs are banned by WHO, but still in India, we are able to access much of the drugs are being FDCs here. As you can see, 80% of the cephalosporin is fixed drug combinations. Again, it's come almost 100%. Most often macrolides and FDCs, quinolones are FDC CNS. And again, when you look at the national list of essential medicines, most of the drugs are out of the list that are being consumed a lot. So what does it indicate here? It simply says that unregulated drugs clearly indicate pharmaceuticals influencing and marketing. See how much of these unapproved drugs are being consumed. It indicates that they are able to still influence the market here in India and able to sell it to the patients, and it's going up. The problem here is so we talked about a lot about regulation. The problem with Indian regulation is there is one central regulator and each state has their own regulators. So each state can approve drugs individually. So there is no single way of approval. So one drug need not to go to the central approval. So Tamil Nadu can approve a drug and it can be utilized anywhere in India. But the problem is not the state level regulators are equipped enough to handle these kind of drug approval or the surveillance. There is completely in shambles. That's where the problem comes, because the problem is we are trying to chase the tail after releasing the tiger out in the wood, because once you approve the drug, there is no point of you going and telling that these are all unapproved drugs seen in the market, because each state regulator are able to give that drug out for approval. That's a problem in India, and there's still a big issues that, as we can see here in the previous slide, much of our drugs are unapproved drugs. Then coming to what are the AMS determinants that influence at the individual level, the first, many of the papers looked at lack of appropriate knowledge. We do all understand not that every doctor can be equipped about all the drugs all the time. But the problem is nobody is looking at marketing influence greatly. But the problem is this lack of appropriate knowledge is being influenced by your marketing influences. That's where the problem comes. You can't substitute our subpar knowledge with marketing influence that will lead to catastrophe both to us and to the patients. So we need to have other alternative ways to update our knowledge rather than depending on marketing influence. See, this is a qualitative study from the drug dealers of wholesale drug dealers or drug inspectors all across the India. If you all and the marketing people, if you ask them what is their motive in here, they're simple. They tell it's market driven, it's money driven. They have a quota to sell to the doctors. This much of drugs should have sold to this many doctors. If they have reached the quota, they will get incentive and they need to get more quota. That's what happening everywhere, and nobody can deny that here. Coming to, if you just ask any doctors in the Indian country, you see, everybody agrees. If you ask a doctor, this is again at looking at the attitude of doctors towards medical representatives, giving them advice here. So if you ask the question, do they think that MR visit is the only way to learn about new drugs? 85% say yes, but that is shows a very serious status of affair in our country where the doctors rely for MRs to update their knowledge. But if they ask the question, do you think that MRs as a source of correct information, 56 still feel yes. But when you ask them, do you feel that MR exaggerate the benefits of medicines and downplays the risk, 70% again agrees. So everybody knows that they are want of knowledge, but MR are providing, and what they are providing is not everything they are providing. They are trying to promote their and hide the risk. That's what is happening. So and they are trying to influence. See, 70% say they influence the prescribing pattern, and they are 65% say they do provide some kind of incentives to the doctors. And if they are told that somebody knows what is the guidelines, so we talked about so many regulations, everything, but 30% only know something exists, even about code that talks about pharmaceutical industries and the relations with the doctors. So, but if you ask, do you think there is a need for strengthening of ethical norms to regulate to physician pharmaceutical industry? Said 80% of the said yes, because everybody knows something unethical is happening here, and they need to do away with that. So coming to this is look at the forest plot, looking at various studies, whether marketing or MR influence or prescribing, whether it influenced the prescriptions. As you can see, whenever there is a promotion, it always end up in getting the prescription from the doctors. The problem is the studies of exposure to information provided directly by pharmaceutical companies have found association with higher prescribing frequency, higher cost, and lower prescribing quality. So it compromises the doctor's quality of prescriptions by influencing them, and did not find any evidence of improvement in prescribing associated with exposure from information from pharmaceutical companies. This is again a survey from the doctors where they were asked whether medical representatives add value to doctors' medical practice. Only 33% said yes, but they also said yes because they want to know what is happening in the market, what other doctors prescribe, what is happening in the market. And 53% felt that they're not adding any value. Value means they might tell about the drugs availability, but they will not add knowledge about the drugs to the doctors. That's what's the underlying here. So the problem is not only it's about the medical representatives that we are talking about. Say it's not direct advertisements to the physicians. There are multiple other things that can happen as discussed, direct to consumer advertisements, though not available in India. It still happen in many other countries. So they can holding the conference, which many of them are sponsored by them, scientific meetings and medical educations where they have a stall to also explore it. Coming to a problem, I said, see, there is no free lunch anywhere. To look at the expenditure of pharmaceutical, you see the huge chunk of their expenditure is going to face-to-face promotion. $50 billion at 2012 in the US. It is as equal as their R&D, research and development. So why in the world a company would invest so much in promotion more than their R&D is because that is the way to get to the pockets of the prescribers so that they will be able to be influenced and able to deliver the drugs to the patients. Again, coming to this is the Indian data again, which looked at annual complaints about media violations, especially whatever the things available. The primary problem is going to be healthcare with 1,500 violations, which is the predominant violations being here. is seen in the healthcare. Again, if you see many of these ads from the pharma companies of the drugs are the problem here, because they claim they are able to prevent and cure superior quality, which is not true. So that's also a problem again seen in India. We have discussed so many acts here, but the problem is in India, we do have so many acts, but the problem is no one is there going to implement it here. So they think even this uniform code of pharmaceutical marketing practices, which is came very recently, 2024, from the Ministry of Pharmaceuticals under the fertilizer and chemical. So the problem here is it's a voluntary statute. It's not yet mandatory yet. So it's still, it's a gray zone because there is no punitive measures. Even somebody violates, no one can be done anything about it. So again, I will take you some examples in here, looking at the Carbapenem. Japan and India and China used. But if you see, what is the thing?
Sir, I think we are losing you in between.
Yes.
Yes, Anas sir. I think sir is rejoining.
Sorry, there was brief interruptions. As you can see, there is again the social media post about naphthromycin. The government came up with the then it's a fake news, because who would in the world say would put up a naphthromycin with the prime minister for the promotion here? Then they said it's a fake news. Coming to about awareness, see, all the companies talks about there is in India, it's not legally you can do a direct advertisements to the patients, but these many vaccine companies do promote indirectly, saying that they are doing awareness campaign, but indirectly promoting their vaccines. So it's not only the medical representatives coming to tell you that this drug is going to work. That is okay. We accept that. The problem is there are many other underlying issues that we need to be addressed, because what happens here, the problems are you can exaggerate the drug's benefit. They can de-emphasize the risk. They may not fail to offer a fair balance of risk and benefit information. They can misrepresent data claims which is not appropriately backed by facts, make an omit material facts about the drug, which could be a adversarial to the drugs. So it could be misbranding. So many of things can be hidden and when they present to the doctors here. So my conclusion is here, if you think pharmaceutical promotion, I would always say it's over promotion, because there's always a vested interest, because they are profit driven, and it always comes with the unethical practices, because they are all in the world of cutthroat competition. They need to win the battle. So the problem is always patients end up with unnecessary antibiotics. So the solution is, I understand we need to be updated, but that should be done by professional bodies, should take up the lead rather than the medical representatives or the pharmaceutical companies. And it should be done through our webinars like these, our CMEs, then WhatsApp groups, then the pharmaceuticals doing that job. That I think we can't substitute our work by pharmaceutical companies. That's my thing.
Thank you, sir. Sir, Venkat sir, do you want to add any points?
So, okay, just 1 second. You're able to see my slides, right?
Yes, sir. Yes, sir.
Yeah. So, one thing I would just like to highlight in a couple of minutes is that, see, although this act was introduced in 2024, there have been repercussions. People, physicians don't go scot-free. Okay. So this was very recently, just about 2 months back. Pharma company spends rupees 1.91 crore on foreign travel of doctors gets reprimanded. Okay. And the audit found that medical professionals took undue advantage from this company for extravagant pleasure trips in the guise of conferences. So it is the law is at work. Now, this act, which we discussed, Uniform Code for Pharmaceutical Marketing Practices, UCPMP 2024, that was breached, and the Apex Committee for Pharma Marketing Products under Ministry of Chemicals and Fertilizers, they found this pharmaceutical company that was a subsidiary of the United States-based company. They found it guilty of sponsoring international trips to the tune of nearly rupees 1.91 crore for 30 doctors. So there definitely the law is at work, and we may believe that just there is over promotion, but it is within the checks and balances of the law. Okay, so even if you take a medical representative who comes to me, I'm thinking of situations in the future where I will be made aware of the presence of a vaccine such as pneumococcal conjugate vaccine 20 or a new drug. Let us say tomorrow Astrianum avibactam comes into the market, and cefiderocol, if it comes to India. Even currently, just as far as a few months back, 6 months back, we see that avibactam, plain avibactam, is now available in India. So I was made aware of the presence of the molecule, not about how to use it, not about the it should be used in so many cases, and it's been promoted. At least the awareness of the product is made to the physicians, and without that, in today's world, it is not possible to know what kind of drugs are available, because ultimately we're not living in the United States. We're living in a country where a lot of the products that we want are not yet available in in a widespread manner. So when we are made aware, that is something that you can call it advertising, but at least it is some kind of awareness. So the other thing I'd like to say is that this will be my last point, that see, there is a lot of mistrust of physicians, allopathy, healthcare, especially if you look at the anti-vax movement in the United States. Okay. That is because we are no longer neutral, but we use our powers to push our agendas, punish wrongthink, and silence dissent. Okay? So the powers think that control is the cure for disinformation, but that is not the case. We need to have honest conversation. We need to put our foot forward, and we need to be able to say that yes, these are the risks, these are the benefits. I was made aware, and that is why if you see any major study or any major all major conferences, you have the conflicts of interest disclosure. Okay, so it is we need to relinquish this control, and that will lead to a free market of ideas, and that really leads to a proper solution when there is increasing trust in physicians and healthcare. Thank you.
Thank you, sir. Prasanna, sir, would you like to take?
Yes, yes. I think Venkat, so these are my concluding slides. So I think this is the mantra for pharmaceutical companies. That's called 3 C's. So understand the customer, the patients, or the doctors. Consider company strength, where you should pitch your things, and assess the competitions. But the problem is this mantra has been altered now. I will just give an example of even from what Dr. Venkat only said. See, if you want to depend on them, I understand promotion is different from, as I said, there is a fine line. The fine print is always missing from the promotion, which needs to discuss threadbare about the drugs, which is not happening always from the pharmaceutical companies. That's the problem. I'm not telling that they are only promoting. The problem is they are promoting only the drug with only the possible uh, good things about it. They are hiding many of the facts behind. That's the problem is. So the second thing is, even he, for his take his own example, though that he was made aware of a drug, he needs to still depend on multiple other eminent people from the field or the literature to see that what is, because he can't rely on just the pharmacy person to decide for the patient, because he knows that he is not going to be fully blindly depend on that pharmacist or medical representative and take his words at and everything and to do that, because he wrote so many emails to so many people that indicates that he needs to cross verify a lot, because he can't trust him blindly. That itself is evident from Dr. Venkat's own case history. Again, I'll come to that. See, now the problem is we all understand if it's a consideration what they are coming to, it's okay. But the problem is they are trying to convince us use our drugs. That's where the problem comes. So consider our drugs is different from convincing use it. That's what they are doing now. Convince is possible, if not confuse if necessary. Like Dr. Venkat did, he said, now the law is catching up all these culprits. He said, see, he said the law is catching up. He said the company was reprimanded and the doctors were reprimanded. But he never said what happened to the company or not to the doctors. Till now, no action was taken against the doctors who all traveled to the international destinations. No action taken. Did you ever hear NMC suspended the license? No. See, just it's a warning given to the company. Did they see that was 1.9 crores was spent by the company to sponsor the travel of the doctors to a foreign destination? It was not the fine. So they didn't pay any fine. So reprimanded is that there is, because it's a voluntary statute, they were warned. That's the reprimanded. That's what he is telling. If not, they will said whether the CEO was arrested, whether the company was suspended, whether the company license was suspended. Nothing is. Have you ever come across these 30 doctors who travel to international destinations suspended? Nothing happened, because they all well showed just a show cause notice. That's all. It ended there. That's where the problem. So they are just confusing us the same way they will do that. And at last they corrupt. If nothing else works, they will sponsor. They will try to give us everything they need, and they will able to spell their drugs. I think this all denotes over promotion. Current atmosphere is for over promotion, because in the cutthroat competition world, they are out looking for their own drugs. It's not for the patient's benefit. So it's acceptable. We need to be aware of it. There's nothing harm in knowing their strategy. We need to be aware of it, and we need to utilize them carefully. And we should depend on our own knowledge and from literature review or CMEs to use our knowledge rather than depend slowly on pharmaceutical company promotions. Thank you.
That was a wonderful debate. Thank you, Venkat sir and Prasanna sir. And yes, I agree. I mean, definitely pharmacy has a role in bringing out like newer molecules, but definitely I think, I mean, as ID physicians, maybe we are thinking in terms of antibiotics effects on whether it has any action, but other physicians may not have so much time to think about it. And like we have had a lot of Carbapenem prescriptions, lot of antibiotics which have been misused because the pharmacy promotes it. So once again, thank you both for making time from your busy schedule and being a part of this. Thank you, sir.
Thank you. Thank you.
Thank you.
So with that, we move on to the next topic. So next we have an interesting topic. So the MSP guidelines are critical, but should they be strictly reinforced or should voluntary compliance be encouraged? So our next panelist will debate about this critical question, whether mandatory versus voluntary MSP, should compliance be enforced? For that, sorry. Yeah, I'm not able to do this. Just a second. For debating on this, we have Dr. Raksha Kochi. She's a consultant microbiologist and infection control officer at Manipal Hospitals, Millers Road, Bangalore. And we have Dr. Debabrata Das. Sir is assistant professor in Department of Microbiology, AIMS, Mangalgiri. So before we move on to the session, let's try to get the polling done. So again, it's the same thing. You can scan the code or you enter the vworks app and enter the codes. I mean, I think I'll try for the last time. If not many are participating, we'll not just have polls from the next one. Okay, we have very less participation. I think we will have in the chat box. I think that would be sufficient. So let's move on. Over to Dr. Raksha and Dr. Debabrata sir for your talk.
So, good evening, Dr. Akshatha and all the panelists in this debate. Am I audible, Dr. Akshatha?
Yes, ma'am. Yes, ma'am.
Yeah. So, I'll start sharing my screen. Just let me know if it is. Is it visible? I will Is it visible for everybody?
Yes, ma'am. Yes, ma'am. Visible.
Firstly, thank you for the opportunity, Dr. Akshatha and AMR Declaration Trust. I really like the topics that have been chosen. And when you gave me the list of topics, like what would you like to speak on, this is something which I'm really passionate about, of getting antimicrobial stewardship in place, both in the hospital and community. So what I had chosen was the voluntary aspect of antimicrobial stewardship. So before I begin, a small disclaimer. So I've been pitched against Dr. Debabrata Das. Now, to share something, if you all see this picture, this is a picture from the Bhagavad Gita with Krishna and Arjuna. A small history that I have with Dr. Debabrata sir is I have attended the AIMS Mangalagiri workshop of antimicrobial stewardship. So there is a quote in this Gita, chapter 4, which says, Tadvidi pranipatena pariprashnena sevaya upadekshanti te jnanam jnaninas tattvadarshina. That means to say, when you are getting into an argument with your teacher, who is wise, you have to ask the relevant questions. So in debate, I hope that we ask each other relevant questions, and in the process, we understand what is the mandatory and voluntary aspect of antimicrobial stewardship. So all of you would have heard about this term called Dandam Dashagunam. What does it mean? We would think that if you hit somebody with a stick, 10 qualities would come out, isn't it? So that would say punishment is more effective than giving education. The amount of CMEs that we conduct, the sessions that we have, training sessions, in center, online, offline. Does that bring discipline into our healthcare professionals? And does it make learning more effective? And that is the question. I would say this is a misnomer that, if you make it very strict, they are going to follow. It actually means, Dandam Dashagunam actually means there are 10 uses of a stick. So you can approach antimicrobial stewardship with 10 approaches, which I'll talk about in the later slides. So the 10 uses of stick on a lighter note is to keep away birds and dogs. This is actually the meaning of the entire sloka, and it is to fight enemies, to support elderly as a walking stick, to help walk in the dark, to check depth of a river, to check the mud, sand, or quicksand. Of course, antimicrobial stewardship is a quicksand right now. To help the blind, to fight snakes, to play games. So this is just on a lighter note. But what about these rules? They are meant to be broken. So if you see in your hospital, you would have a high-end antibiotic policy. The forms are not filled. Neither is the OPD prescription following your policy, and you see high-end antibiotics being prescribed in the hospital, despite the rules being there, and it is being made mandatory for the physicians to follow. Just a article that I came across to cite a simple rule in the community antimicrobial stewardship, which we're talking about, you would have seen this red line on the strips. Now, this is a study which looked at the awareness of this red line. Only 7% of healthcare professionals know about this red line. Despite this being a mandatory rule that, without this, without a prescription, antibiotics are not supposed to be given. So the rule is already there, but nobody is following it. And none of the patients were aware of this rule. And this was an article published in 2022. Now, let's come back to our own hospital settings. Now, you try telling a clinician, fill the request form completely, avoid empirical use of vancomycin and meropenem, stop sending swabs for culture, always send paired blood cultures, not a single bottle, avoid prescribing linezolid in OPD without justification, do not treat colonization or treat infection. I'm very sure all of us would have done this at some point of the or the other. Today, I had one of my gynecologist sending a swab for culture, and we had a discussion regarding the amount of pus that was present on the swab. And the answer is, of course, from the clinicians that they can't. It's like a toddler tantrum that you have with them, isn't it? But what are the answers that you get from them? They tell you that filling the request form takes too much time. They can't wait for the culture reports, and the patient is very sick. They need to start those antibiotics of vancomycin, meropenem empirically. Swabs are, of course, easy to collect, and they need some samples to send. And one blood culture should be enough because multiple sets are difficult to take. We understand these are practical difficulties. Linezolid is a good drug. Why not give it on a OPD basis? I mean, how do you justify that? And of course, your culture reports. Of course, there's an organism, so I have to treat it. So these are the kind of answers that your clinicians will justify with. If you see this picture here, there's an elephant over there. And just imagine this is one of your committee meetings where everybody is there, including your, administration, clinicians, infection control, pharmacists. Each person has a perspective towards antimicrobial stewardship. Not that they are wrong, but their perspective in individual terms may be wrong. So if you touch the leg, you feel it's a tree. If you touch the tail, you feel it's the rope. So this is just a old poem by John Sachs. It says, though each was partly in the right, all were in the wrong. So your antimicrobial stewardship is like an elephant in the room. Although it is present like a big problem, we don't understand that this is a problem. Nobody acknowledges that. So where do we begin with this concept of making it voluntary or mandatory? We should understand that many times we feel we don't know what we need to do. How do we go about this? So I'm sharing an article here. This is by a wonderful group which is working on the social and behavioral aspects of antimicrobial resistance. This was published, I think, way back in 2013 by Esmita Charani et al. Now, what they're talking about is there are rules, but what are these rules? These are more of a cultural rules. Like unit one prescribes a particular antibiotic, it becomes like a tradition that that unit prescribes only those classes of antibiotics. This is a prescribing etiquette that is present in many of the units. This is apart from the antibiotic policies that you have in your institute. Also, there's an important concept of the language of antimicrobial resistance. We have been talking about this day in and day out, and almost like we the words that we use. It's like battle against AMR, war on superbugs, combating these multi-drug resistant pathogens, menace of microbes, post-antibiotic apocalypse. First thing we need to understand is we live in the world of microbes. We are in their world, and it is not vice versa. So, how does this language stop us from implementing antimicrobial stewardship? Now, this is a wonderful article. It says the language of antimicrobial and antibiotic resistance is something which is blocking global collective action. In this regard, when we say voluntary and mandatory, I'll come to it. Like, what do you mean by mandatory? What happens if it is a rule and it is not followed? So, that's a big question. Now, say you make an antibiotic policy, a wonderful policy in your institute, and you tell the clinicians you implement it. You just look at the picture, you take a horse to the water and say, drink. Is that horse going to drink? No. It has to come from within, isn't it? So this is another article which says about the opportunities and challenges in antimicrobial resistance, behavior change, communication. Now, in this article, there are three concepts that were put across, looking at the modes of persuading your healthcare professionals to get into antimicrobial stewardship. One is your logic, that is called the logos. You give facts and evidence-based communication. Second thing is your pathos, that is your emotional appeal. You engage and inspire a behavior change in them. Third thing is the ethos. You build the credibility and trust. Make role models for responsible use of antimicrobial stewardship. Now, there is a voluntary component involved here because this has to be proactive. This cannot be made mandatory. Now, if you look at different components in this, the logic aspect, there is rational prescribing, there is clear communication and guidelines adherence with the antimicrobial stewardship team with the updated guidelines. Ethos, you have lead by example, educate and engage them, collaborate with the experts. And coming to the pathos, the emotional aspect, you have to have a personalized AMR impact, share real patient stories. Here comes the involvement of your patients into antimicrobial stewardship. And also, there has to be an empathy driven counseling that has to be done. Many times in our antimicrobial stewardship, we forget this approach. We are always talking about the recovery, finances, the patient stay in the hospital, but the emotional and mental aspect of the burden that AMR is bringing on the patient and of course the clinicians on choosing the antibiotics is never spoken about. So there needs to be a collective responsibility that needs to be brought in the team itself to practice antimicrobial stewardship before even thinking about making it mandatory. Now, we were discussing about the global action plans, also about the 5 strategic objectives. I'm not going into the details of this, but if you just look at the order of the objectives, the first objective itself talks about the behavior change. Now, there is a reason why this is put as the first objective. There's a chronological emphasis that is made because participatory approach is the only way, and this is not an accidental placement in the global action plan of WHO. Also, if you remember, Alexander Fleming had quoted in the Nobel Prize lecture that he had given us a warning that there is a danger that the ignorant man may easily underdose himself by exposing his microbes to non-lethal quantities and make them resistant. But we didn't pay heed to it. So this was our first warning actually, and the first missed opportunities. So even before making rules, we need to look at what our scientists and what our clinicians are talking about and where exactly the intervention has to be made. So how do we approach even before making rules? Is we have to think about where is the area for improvement. There are multiple ways of approaching it. This wonderful table shows you the strengths, weaknesses, opportunities, and threats that you can do in your own institution or place, or even at a national level, where you can look at implementing programs. But the reality is, we have many audiences. Our audience is diverse from primary centers to tertiary centers, from community to, uh, you know, nursing and, clinicians, pharmacists, then regulatory bodies. And there's so many things happening with antimicrobial stewardship. And that's why there are many messages. But is there a collective result? That's the big question. And that is a high cost for all of us. Next comes the body. Non non why some
Ma'am, you're not audible.
Hello.
Yes, ma'am. Now it's audible.
Yes, I'm audible. Yeah. Okay.
Yes, ma'am.
So, coming to the behavior approach of the clinicians, if you look at this table, why do they reject the antimicrobial advice that we give them? Basically, there is a personal interest involved, inadequate stewardship, lack of flexibility, fear of making a mistake, no response from the administration. Then there is this concept of I've always done this way and it works this way, and there's a lack of knowledge, and there is a sense of entitlement and power. I am the senior clinician here, and this is the antibiotic policy that I have made for myself and my unit. So there is a lack of ability to accept the new guidelines. Now the question is, if you make it mandatory and if they don't follow, what are you going to do? So there can be sanctions. You can have positive sanctions if they do follow. So you can encourage them by giving them some award and give and say you are the best unit, you have the best compliance. If they don't follow the negative sanctions, that's a real question. What are you going to do about it? You can have formal sanctions, by really praising them and giving them some sort of reward by telling them this is you are bringing in a lot of revenue, or generating a lot of revenue for the institute, give appraisals. So all those things can happen. Informal sanctions is what most of us do when we say, oh, when we talk to that clinician, he's not going to de-escalate, meropenem is his choice, linezolid is his choice. So gossip and those kind of things. So this is a real question. If you make it mandatory and they do not follow, what punitive action is what you're going to implement? So that's a big lacuna that we have. So how do we approach it? The main question is, how do you make the clinician think, what is in it for me? What is in it for me in this antimicrobial stewardship program? If I follow this, what is that I get out of it? So coming to the 10 ways back to the stick that we were talking about, how do we get the clinician buy-in for antimicrobial stewardship? With some of them I have tried and seen success to some level. Education and awareness campaigns, of course. Incentivize them. Even a small chocolate would do it sometimes. Peer influence and role models. Compare units in a positive way and tell that unit works very well with the antibiotic policy. Give them simplified decision support tools. Nowadays you have a lot of clinical decision support systems, and your AI and data analytics can be used for this. Feedback and self audit. Make them audit their own unit. Integrate the AMSP into their daily workflow. Have a shared decision making. Your clinical microbiological rounds will come into picture. And have a patient centered approach. You have a multidisciplinary collaboration, and have a positive reinforcement instead of having a punitive measure. So telling that it is mandatory to follow, it's like tying them up and telling, you have to follow this. More than that, making it voluntary and giving them a support system to back up on would be a better approach to get antimicrobial stewardship in place. So I would like to say that all things are possible in our antimicrobial stewardship efforts. We have seen a lot of things happen, a lot of things don't happen. So many times it is 1 plus 1 equal to 3, but and the whip doesn't work every time. So you cannot beat, the antimicrobial stewardship policy through the system.
Thank you,
So,
ma'am.
yeah,
Yes.
this is just to end. This is Dr. Debabrata Das teaching our batch. So, sir had told read during the antimicrobial stewardship session on the M100 policy. So, I'd just like to conclude here. if you would have seen this movie, The Dirty Picture, where no, the actors quotes entertainment, entertainment, entertainment. That's the only way to go across. Antimicrobial stewardship is not a dirty picture. It's a good picture. The only way, according to me, is involvement, commitment, and willingness. These are the three things which we should look for before even thinking of making it mandatory. So I would like to conclude on this aspect. Like, say, I spoke about the horse. A good teacher will lead the horse to water, but an excellent teacher will only make the horse thirsty first. So even before making rules, we should think of making the clinicians understand how important this is. So I would rest my case on this. Thank you.
Thank you, ma'am. Over to Debabrata sir.
Hi, Dr. Akshatha, just let me, yeah. Are you able to view my slides?
Yes, sir. Yes, sir. It's visible.
Thank you, Dr. Akshatha, for giving me this opportunity. And I would like to thank Dr. Raksha also, that madam has just told everything, but the path that led to his or her presentation is mandatory AMSP. You need to tell the clinicians that it is a mandatory thing and you cannot be just sit on voluntary. I just ask Raksha madam that how much time will you give to all the clinicians to be voluntary, and when you will take your Dasa Dandam, and when you will take your will. So ultimately we'll need to tell the every healthcare worker that AMSP is the thing, and today or maybe after 1 year, it is going to be mandatory for their respective hospital. The very fact that we have our conversation regarding this AMSP, that we are a bit of ill understood about the AMSP. What is the purpose of AMSP? The right drug, right dose, right duration, and right route of administration, isn't it? So if that is the thing, just tell me how many healthcare worker will not fall upon this thing, but still they are not doing the thing because maybe there is a chance or there is a problem in our education system, or maybe an availability, or we are just stricken the term AMSP. The ultimate goal we have is to improve the patient care and healthcare outcome, isn't it? Now that the same guideline what Raksha madam has told, I am also projecting the same thing, that what are the modifying behaviors. Now, if you see that in the introductory remark of that very article, it is talking about the outlier. And what the outlier is, that the observed behavior of the outlier is markedly different from that of the peers. In our country, the problem is the outlier is the norm. And if you see that same article, it is there, and we hear that day in and day out that my patients are different. In my experience, guidelines are non-specific, so on and so forth. So what is the outlier here? The outlier is the majority of the clinician. How are you going to deal with them if you keep on telling that it is voluntary, it is voluntary, it is voluntary? Now, what I am quoting another article from Journal of Global Antimicrobial Resistance about the antimicrobial stewardship capacity and manpower needs in the Asia Pacific. So if you see here that the last point, culture guided de-escalation were reported only in 24% of respondents. And here the countries, if you see the first point, there are 16 countries, and that the thing is global. Here the participating countries are from China, Australia, Vietnam, Thailand, all over the
Southeast Asia, and still we have culture-guided de-escalation were reported only in 24% of the respondents. Now, this is then extra that slide that since we are into the infectious disease, we are into the microbiology, we are seeing this slide from the day it has been published, isn't it? And still, if we are talking about voluntary participation on AMSP, then we are ridiculing this figure, isn't it? Now, just tell me, and I am going to give you a non-medical example. We all know in our country, the financial year ends at 31st March, isn't it? Now, how many of us are getting Form 16 on the April or May? In my experience, it is always the late June or the July, and then also we are thinking of extending that deadline of ITR return, that is 31st July. Now, the CA or the finance department only providing us the Form 16 in the late June or July because there is a deadline and it is a mandate by the government of India to fill the ITR, isn't it? So are we going to tell them voluntarily give us on April or May so that in time we can file our ITR? It is not going to happen, and it is not happening. This is our personal experience. Now, then we have our own problem. This is the AMSP that the IJMR article where we have 20 tertiary healthcare institute, and still there is the AMSP practices rudimentary. We may tell them that, or we may have our justification. We are the largest country or by the population. We have so many patients per clinician. But if we see that these are the premier institute of our country, the 20 premier institute, tertiary care, healthcare institute, where the AMSP is rudimentary, and we are thinking of telling that this should come voluntary. Now, if we talk about the guidelines, let us accept that unless until the NABH comes in, how many of microbiology or infectious disease physicians are there in hospitals? There were none. Just because of NABH accreditation, they are hiring these microbiology people, infectious disease people, isn't it? Then why can't we form? And then here in the latest edition of the NABH, this is one of the core element for an antimicrobial stewardship program. Now, if you have to get an NABH, this should be there. Now, why NABH is asking for this and making a mandate? Because we have seen that people are not following the things if we are telling, or so-called that it is desirable. It is not a mandate. If it is a desirable things are going for a out of boundary from the clinicians, isn't it? So we have to do it mandatorily. Same thing is there for the JCI, the R3 report, where they have augmented and the revised requirement for antibiotics stewardship. And those who are going for JCI accreditation, they have to follow these rules. Again, these are the mandates and not desirable or voluntary things. Now, what we think is required for implementation of AMSP, isn't it? Every time you tell any of the treating physician about AMSP, they will talk about these things, isn't it? MALDI-TOF, your BioFire, your automated AST system. I will just ask, when we break a traffic rule, do the traffic police tell whether you are driving a BMW or you are driving a entry-level hatchback car? Or for that matter, do they ask, are you a novice driver or are you an expert driver? They put the traffic rules equal for everything, isn't it? Now, we cannot tell that we don't have these facilities, so we cannot implement AMSP. What AMSP actually need? These are the 4 elements that the AMSP need. That first is, does my patient have an need of an antibiotics? Now, this is our basic MBBS knowledge, our postgraduate knowledge, that whether the patient has an infection or not. I will tell my experience. During my internship, it was taught that any patient you receive in the emergency, start with a pantoprazole injection and a ceftriaxone injection, and then give a call to the junior resident. So that was how we are taught. We are not taught about the adversities of the, and we are not taught how to differentiate the whether to give an antibiotic or not. And I believe till now the norm is like that in many of the hospitals. Then there is no culture. If there is no culture, you cannot tell that the patient is actually having an infection, or are you getting the right etiology or right organism for that infection. Now, you may argue that every hospital doesn't have a microbiologist who have restricted them to appoint a microbiologist. There is too many microbiologists now available in our country. So why they are not appointing? Because of money factor. So if you are talking about the AMSP, the core element, it is first the administrative liking. We have to tell the administrator that these are the things that you need to do, and this is the mandate. And any hospital or any sane administrator will definitely agree with you. And then whether it is to be stopped or it is to be continued. I have seen patients in premier institutes that piperacillin-tazobactam is going in for 25 straight days. Is it justifiable? And will we still tell that this is the time that we are going to ask them for voluntary antimicrobial stewardship that should come from within 25 days of piperacillin-tazobactam, and there is no improvement or no there was no improvement, nor there is deterioration in 25 days, and in between there was no culture sent. So how will we justify of the voluntary awareness and the awakening of the clinicians if we do not have anything to tell that we have a policy in force? If you have to abide by the rules, if you are not going to abide by the rules, you have to face the consequence, and that consequence have to be remarkable. As you told Raksha madam, that there should be an appraisal or encouragement if they are following. Now, when you are telling about any punitive action, this punitive action has to be there. That punitive action can be your morbidity, mortality rate. You have to discuss. It is not that always a treating physician should choose a case. We should have the right to choose a case, and where those treating physicians erred, and we have to tell them and shame them that these are the things. Now, when we talk about these things, we have this, and it is back in 1993, the BSEC has done a survey, and it was found that the knowledge about the antimicrobial prescribing is lagging in many of the treating physicians, and which is the major cause of the misuse. And in this situation, the prescribing physicians prefer to err on the safe side and prescribing maximal broad spectrum treatment instead of making a well-informed guess. And when we talk about, and when we are talking about teacher, and we are talking about a good teacher or good policy maker, we always tell that don't go or don't trip about the solution problem. We should have an solution also. So this is one of the solutions that the BSEC party has formulated, that in case of patient, it is the shaping the behavior that antibiotics about the antibiotic in the primary school and then in the secondary school, and then who those who are more than 16 years, you can have a national campaign. What about the prescribers of the antibiotics? Well, we also have the undergraduate curriculum, which is barely same as this age group, 18 to 25. Then the internship, and then the professional training. Now, when we talk about these things, this is the shaping of behavior. Now, whatever has been shaped in the postgraduate education, we need to have the intervention studies or strategies so that we talk about the proper training to a postgraduate and a treating physician. Now, when we talk about premier institute or tertiary care hospital, we always come upon the thing that they will tell that the patient has come from various nursing homes, various primary care hospital or secondary care facilities, and they have bamboozled with so many antibiotics that we are only getting resistant organism. Now just think that when we are talking AMSP, we are not talking about the premier institute. We are talking in the training level, so that whenever there is a patient received by a healthcare professional or treating physician, they should know what is the things to be done when it comes to the antibiotics. If such thing happens, and if such mandate is there, we no longer need, or we no longer have that problem that in the tertiary care hospital we will be only dealing with the multi-drug resistant organism. Now, as you already told also, that when we talk about the stewardship program, it is taken as antibiotic policy, and that too unsolicited oversight, and it is a very intrinsically uncomfortable to tell them that they were making the wrong choice. But do we have any option to tell this pill taken differently? We don't have. We have to tell where there is error. There should not be any ego. The problem in our country is the specialization that we took based on the rankings, and the rankings give a sense of upper-handedness, who are taking the clinical branch and who are taking the non-clinical or paraclinical branch. We have to remind everyone and all the teachers in the medical college also that when we are entering the postgraduate, we are on the same page. We are starting from point zero. So, so that there won't be any conflict when we will be telling them that this is the wrong thing that has been given. So, as the Notebandi has everyone on their toes to change their notes, wherever stacked or not stacked, white or black, they are there lining up in front of bank, no matter how hard earned or how ill gotten the money is. Now has the time has come to tell everyone that this has to be a Notebandi, or antimicrobial stewardship is not about we are talking about don't give antibiotics. We are telling them to use meropenem when it is needed. We are telling them to use colistin when it is not needed. What we are telling is use it judiciously. Don't just tell that whenever there is a patient admitted to an ICU, meropenem, vancomycin, and fluconazole is just under treatment. You are demeaning your training there by not telling that or not differentiating whether it can be a gram positive thing or a gram negative thing or a fungal infection. We cannot have all these things at one go, and there where we need to have a mandatory AMSP practices. So this is my last slide, and I just want to conclude and had it in a physical seminar. This should have been my only slide, that AMSP is the mandate. Thank you.
Thank you, sir. So, time for rebuttal. Dr. Raksha ma'am, do you have anything, any points to
Yes.
add?
Yes, yes. I'll just share my slide, few slides on that.
We'll have it quick so that.
Yes, yes, yes. Is it visible? Is the
Yes,
slide
ma'am.
visible?
Yes,
Yeah.
ma'am.
So as we were discussing right now, agreeing with Dr. Debabrata sir, antimicrobial decision making is really complex. You really have to see which setting you're working in, what is the patient's sign and symptoms, whether the diagnostics is in place, whether the patient can afford those tests, whether do you have that time to decide what antibiotic to give, how to give, when to give. So we are a very diverse country. So what I feel is also before we make it a mandate, we should look where we are coming from. There's so many questions to this problem, like where, who, why, how do we go about it? When we say we are going to make this a mandate, we have to see the implication of that and see how is it going to serve the purpose of making it a rule. Of course, in a center where everything is in place and diagnostics is there, infection control committee is there, all these things can be addressed at a level where when the AMSP doesn't work, you have a plan B. But what if there are no answers and no solutions? So this is a very popular slide, like you cannot uh, penalize somebody for not following antimicrobial stewardship if they don't have the resources at all, isn't it? So this is our current state. As we were discussing, I was just seeing how many hospitals does India have. There are about 70,000 hospitals. And how many are NABH accredited? Okay, NABH has made this as a core standard. Only 1,299 hospitals by 2023. That's about 1.8% of the hospitals which are NABH accredited who go for this, codifying these rules, bringing in the system. What about the other 98 plus percentage of the hospitals, healthcare clinics, general practitioners? How do we make this a mandate in this group of 98 percentage of healthcare centers? So even before we make it a rule, what I feel is we need to provide resources. We need to hold hands in tier 2 cities, villages, primary health centers, enable them with the knowledge, and probably later on, once they gain that foothold over antimicrobial stewardship, then bring in this rule. We have not reached that stage in our country yet. It's a multidisciplinary approach. We were talking about community engagement, healthcare workers, non-medical sectors like your pharmaceuticals. One thing we missed was the administration, the policy makers. That's the another group where antimicrobial stewardship is not realized. That's the real elephant in the room. So we could go on discussing about this. Again, it's a perspective on how we look at making this antimicrobial stewardship, as a practice change in our own settings, and of course beyond the walls of our hospital. So I would like to end with this. So over to Dr. Debabrata, sir.
Sir, would you like to tell any points?
Yeah,
Yeah.
just the 2
Close.
points. When we talk about the complex scenario of this decision making on antibiotic, we always give them a window of 48 hours, isn't it? And after that, at least they can de-escalate or review the situation. That is not happening. And whatever Madam has told about the process of getting into that point, a mandate will escalate those things, like COVID-19. A mandate of PCR, have all the PCR lab flourishing in the remotest medical college of the country. If there is a mandate to enforce the AMSP, these things will get escalated. Thank you.
Thank you, sir. With that, thank you, Dr. Aksha ma'am and Dr. Devabrata sir, for making time for this
Thank you.
and being a part of
Thank you,
this.
sir. Thank you, Dr.
Thank you.
Akshatha.
So with that, we move to the last but not the least topic. So we have the topic rapid diagnostic versus empirical therapy, which should guide the initial treatment. We have esteemed speakers, Dr. Umang Agarwal sir, who is a senior consultant at PD Hinjudha Hospital and Research Center, Mumbai, and Dr. VK Vinit, who is assistant professor and consultant infectious diseases at Enopoya Medical College, Mangalore. Over to Dr. Umang sir and Vinit sir for your session. For the shortage of time, we are not going to have the polling. So Dr. Umang sir, would you like to take, or Dr. Vinit sir?
Shall I start?
Yeah, sure. Sure, Vinny. Go ahead, please.
I'll try sharing it. Am I visible?
Yes, sir. Slides are visible. Could you put it on slideshow, sir?
Yeah, it's in the slideshow.
I think it's not, sir. Do you want me to share, sir? Because it's not in the
Is it visible
slideshow.
now? Okay. Can you just share Dr. Akshatha?
Yes, sir. Sure, sir. I will just share and then
Yeah.
I'll give you the access to change the slides also so that it. So could you stop sharing?
Yeah.
Yes, sir. I have shared the slides, so you can even share. I mean, change the slides.
Okay.
Yes, sir.
I don't think I can change the slides. So, 1 minute. Yeah, I don't think I can move the slides. Would you help me out? I will start speaking.
Yes, sir. Yes, sir. Please.
Thank you, Dr. Akshatha and the AMR group for giving me this opportunity. This is a quite tough topic for me and Dr. Umang sir, because disclosure-wise, both of us are quite interested in point of care tests. Like my thesis was on BCID2, and Dr. Umang as well, I think he's quite interested in this topic. So let's go to the next slide. I'll go with case scenario based for the interest. Next slide. Dr. Akshatha. I think the first slide. Yes. So, am I audible? Am I audible?
Yes, sir. Yes, sir.
Yeah. 56-year-old female. She's a diabetic. Had a renal transplant around 10 years back. She was on TAC and prednisolone. She was on PCP prophylaxis. She presented to the tertiary care hospital with a fever and cough of 7 days. Next slide. Yeah, this was the chest X-ray. As we can clearly see, there is bronchopneumonia, and definitely there is a consolidation, especially in the middle lobe and lower lobes. Next slide. The primary treating doctor involves the pulmonary medicine consultant. undergoes bronchoscopy. Very surprisingly, the pulmonary medicine consultant sends ball for sepsis PCR. So to be very sure, I practice in Mangalore, Karnataka, sir, where we see lot of PCRs. There are PCRs like pan-bacterial, pan-fungal, pan-mycobacterial, pan-parasitological. So it's a lot of times it is being sent without having any idea why it is being sent. No cultures were sent, and cytology was also sent. Next slide. So this is the sepsis PCR report. Pseudomonas aeruginosa target detected, Enterococcus target detected, Mucorales target detected, Influenza A detected, Rhino detected, and the AMR mechanism detected was NDM. So the nephrologist was quite confused what to do next, completely confused. But the patient was already on piperacillin tazobactam at that time. Next slide. So cytology was neutrophilic predominant. There were no atypical cells, and patient was on piptas and doxy. So the primary treating doctor continued the current antibiotics. Okay, next slide. Day 2 of postcopy, patient's heart rate went to 110, BP 98/60, saturation 86 in 4 liters of oxygen, and the respiratory rate was 30 beats per minute. So the doctor was worried what to do, and the ID doctor at this point, I was involved at this point. And when I was involved, when I came to see the patient, just in front of the file, there was one big sepsis PCR report kept to figure out what to do with that report. So patient was already on piperacillin tazobactam. I did ask for 4 bottles of blood culture, each bottle having 10 ml of blood. I did add teicoplanin for a gram-positive curve because the patient clearly had sepsis. I switched to meropenem. And then I was waiting for the cultures. Next slide. The microbiology, we do follow microbiology because microbiologists are the best friends for infectious disease. And it flagged gram-positive cocci, 3 out of 4 bottles. Next slide. Any guesses what might be the organism? Sorry, Dr. Mung, you're mute. Okay, it was a Streptococcus pneumoniae.
Community-acquired pneumonia.
Yeah, it was Streptococcus pneumonia. It was penicillin and ceftriaxone resistant, and it was sensitive to Vanco, Tico, and linezolid. So we had to treat based on the we had planned a directed therapy, and patient improved well. Next slide. So the question is, did the rapid diagnostic test help here? The answer, I think all of us will agree, definitely not. It didn't help in any of those. So if there are RDTs, yes, there are a lot of PCRs. Next slide. This is one of those as per the guidance from ICMR 2021. There are a lot of rapid diagnostic tests. One of the 2 most commonly used was expert Carbar and Biofire, which are quite good validated, whereas the rest of the things we are yet to get good research studies upon that. Next slide. Anybody recognizes this great person? Would have seen multiple times in Robin's textbook or any other textbooks of pathology. We'll go to the next slide. So he's Dr. Raymond. He's a very visionary clinical pathologist. What he observed, he had a great foresight. So what he observed 1974 was our technical capabilities are exceeding our ability to apply them effectively and economically to human population. Another similar observation was today microbiology laboratory is faced with super abundance of academic information and pressure to perform exhaustive, expensive, clinically irrelevant, which when misguided may mislead physicians into diagnosis and inappropriate therapy. This is as per published in Journal of Clinical Microbiology in 2017. The second observation is quite relevant to our scenario. So we got a rapid diagnostic test, we got a PCR, which didn't help the physician. It was almost misleading the physician. Fortunately, the patient, based on the NDM detection, fortunately the patient was not put on polymyxin or any other critical antibiotic. Next slide. So what we need to really look is this algorithm. When a patient comes, we look at diagnostic stewardship and antimicrobial stewardship. In diagnostic stewardship, we try to apply a right test for a right patient at a right time frame. Doing a rapid diagnostic test, once the patient has already developed 3 or 4 inotropic requirements, already anuric, may not help. Whereas it is the first window period where it helps to find out the etiology. What about antimicrobial stewardship? We have to interpret the rapid diagnostic test. So the clinician should be able to interpret it in a right domain for a better clinical judgment. Next slide. So these three are very important. For right test, is the test appropriate for clinical setting? For example, if you have a urinary tract infection and patient is coughing, no point in doing BAL PCR, sending for rapid diagnostic test. Right patient. We already know if the patient is on a palliative care and the prognostication wise patient is not going to do well, no point in spending money on a rapid diagnostic test. Right time. I practice in Mangaluru, so a lot of rapid diagnostic tests, for example, PCRs do take a lot of time. They don't come very fast. There was once we had a PCR which was sent to Mumbai and the report came after 5 days. Before this paper, during the time patient was almost discharged. So the right time frame was very important. Next slide. And right interpretation. The clinician should be able to interpret the test report and plan a right antimicrobial at the right time. Next slide. What about how can we generalize PCR or sequencing from to Asia and Pacific region? So this is one of those just a review article which was published in Clinical Infectious Diseases. Next slide. So this is the ideal patient care pathway. So initial staging, if it is feasible, rapid diagnostic tests. With one of the few examples they have given for rapid diagnostic tests was procalcitonin, rapid flu PCRs. And we should be able to get the result very fast so that we can channelize the therapy. If you really retrospectively think, not every patient we can do this algorithm. A lot of times we as a physicians or infectious disease consultants, we are involved maybe after 72 hours out of the patient's timeline. At that time, doing a rapid diagnostic test or even in 24 hours, will it be really useful? It may depend upon clinical scenarios. Next slide. What about key challenges? One major problem I face is each report you see a PCR, for example, you see a pan bacterial, pan fungal. Just look at the end of the report. There will be one big star mark telling that this is not accredited by NAPL and this is an in-house PCR. So we can't trust those reports and we can't do any clinical decisions based on that. So clinical validation is very important and comparing it in multiple centers with a good clinical judgment is very, very important. Next slide. What about how do we address the barriers of development? How do we tell this rapid diagnostic test is useful or not? Next slide. So that is based on the WHO's assured criteria, which will be very useful in resource limited setting. Assured means A is affordable by those at the risk of infection. A lot of PCRs are 15,000, 20,000. The cost is around 15 to 20,000. So it is not at all affordable. Second, sensitivity. As I told in the first ICMR domain, there are only 1 or 2 tests where they've really looked at sensitivity and specificity. Rest of them, they're yet to get a good result or a research studies based on that. For user friendly, a lot of times people are not trained how to do this test. Rapid. This problem I do face in Mangaluru. We do send PCRs and we end up calling the lab, finding it on the report, and sometimes reports don't come very fast. It takes a lot of time. So it is definitely not rapid in my scenario, equipment free or delivered to those who need it. A lot of times clinician would have to call and trace the report. That should not be the scenario. Next slide. I'll go to next case. So 84-year-old female, she was diabetic, right total knee replacement 5 years back. She presented to the orthopedician who operated previously with the right knee swelling, pain, fever since around 10 days. Total count was 15,000, ESR was 120 and CRP was 180 and the blood cultures were sent but was negative and the orthopedician had sent pus and wound swabs before that time. It was negative. Patient was not deemed to be fit for a staged procedure. She went for DAR. During this time in the OT, fortunately, the orthopedician is a quite good friend of mine. He called me, do you want any samples to be sent? So this scenario happened just 3 months back. And as the patient was exposed to antibiotics before, there was a pus culture sent which was negative. So next slide. So I advised them to send for pus and tissue, both for culture and biofire. Next slide. The biofire was negative. Culture grew Enterobacter cloacae. Now again, the question remains the same. Next slide. Did the rapid diagnostic test help here? Again, my answer is, in this scenario, it is no. It really didn't help. The patient was put on a directed therapy based on the drug susceptibility. The patient is doing well. So understanding the complexity is very difficult, especially of indigenously, rapidly point-of-care diagnostics. This is one of the review article by Dr. Monika Sharma from Indian point of view. Next slide. So a lot of times these are the challenges. There are absence of target product profiles, absence of gold standards for comparison, a long duration of development process, absence of clearly defined process of validation. So a lot of VCRs we do, when we call up the lab, we ask them, is it clinically validated at multiple centers? Their answer is no. They do tell us back, telling that it is an in-house PCR, it is not validated. Sometimes in the report, if you keenly observe the report, you will see the report with a disclaimer, this is not accredited by NABL. My question remains again to Dr. Uman, how will we plan the therapy based on these kind of reports? Fourth one, lack of guidance to undertake feasibility or validation studies and funding. Next slide. So how do we interpret PCR? I think this is the best way. Next slide. Basically, we need to have a team, a lab expert, microbiologist, clinician, an infectious disease specialist, and a molecular biology specialist, where a lot of times we may see targets, especially next generation sequencing. We may see multiple targets with the percentage. We need to really discuss with them. I do discuss with the clinical microbiologist. Then we may have to plan a therapy based on that, if we are utilizing it. So as Dr. Raymond says, just because you can does not necessarily mean you should to the microbiology lab, by stressing the importance of careful integration of what is technically feasible with what is clinically important. Thank you. This is basically from Mangalore. It's a beautiful beach at Mangalore.
Thank you, sir. Over to Dr. Umang, sir, for your perspective.
Okay. Firstly, thank you, AMR Declaration Trust, as well as Dr. Akshatha for this kind invitation for this particular talk. Now, I was asked to talk about pro-rapid diagnostics, but by and large, my dear competitor or my dear friend, Dr. Vineet, with all the flaws stated about RDTs, it still seems as if he likes to use RDT so much, doesn't he? So I think I've half won there. And in the next remaining slides, I'm hoping that I'll be able to convince all of yours that rapid diagnostics are the way to go. And by the way, I do commend all the efforts of Dr. Vinny. That was a very difficult topic against rapid diagnostics that he was given, and I think he's really done a marvelous job. So this will going to be the outline of my talk. I'll start with a brief introduction. We'll talk about a case, and then I'll talk about the rapid diagnostics in an Indian ICU, real world evidence that we did in our hospital. So now this is one of the slides that I frequently portray in my talks. I think it's one of the most beautiful slides ever made. This particular antibiotic timeline was actually published in the International Journal of Molecular Science by Brown et al. In 1900s, when we had no antibiotics available, the three leading causes of death were infectious diseases. Come 150 years later, in 2050, antimicrobial resistance is going to be responsible for 10 million deaths every year, much more than any other disease, infective or otherwise known to mankind. Despite all kinds of antibiotics available to us. So life does come full circle, doesn't it? Just to understand the impact of AMR for our future generations, in 2016, Mr. David Cameron, the then Prime Minister of the UK, requested Jim O'Neill. So he was a leading economist. He was the chairman of Goldman Sachs, and he had requested Sir Jim O'Neill to actually carry out certain prediction models to understand what we are facing really 50 to 60 years from now. And these were his predictions. 10 million deaths by 2050, much more than any other disease known to mankind. The financial impact of AMR is going to be around 100.2 trillion GDP loss globally. Now, the value sounds large, but to really put this into perspective, this particular value is 25 times the present GDP of India. My present talk is about the use of rapid diagnostics. So you must all be wondering that why am I really talking about AMR and everything else? Well, one of the methods or one of the strategies that the Jim O'Neill report suggested was the use of rapid diagnostics to reduce unnecessary prescription and to optimize treatment. So even before I begin my talk, stalwarts such as Jim O'Neill actually support the use of rapid diagnostics in clinical practice. And of course, my dear, dear friend, Dr. Vineet, also likes to use rapid diagnostics quite frequently. So, well, that's half the battle won. Now, let's start with this particular case. We have a 15-year-old student. He has fever with chills 4 days prior to some present admission. Now, over the next 2, 3 days, the redness, pain, and what he started complaining of pain, redness, and watering from his right eye. Certain oral antibiotics were prescribed, but it just was very aggressive, warranting an admission. And he was admitted elsewhere initially, wherein they had started him on ceftazidime for 2 days. However, he was not improving, and that's how he got shifted to Hinduja under our care. Now, his past history is significant for the following points. He had no known comorbidities, but his mother had the habit of spraying Cinnaris oil around the pillow of that particular child. Interestingly, what had happened was just 2 days prior to his symptoms, some of that Cinnaris oil had actually gone into the affected eye. All right. So that becomes a very relevant history in our setting. Moreover, he used to have recurrent skin abscesses over his left shin. He used to take some antibiotics, then it used to settle down. Sometimes it just used to burst open. But this was another thing that this patient had. And when he had actually come to us, there was actually an ulcer in that particular area. So this is not really the image of that particular patient, but this is a representative image, but it looked very similar to this. Lots of conjunctival congestion, lots of periorbital edema, redness, periorbital cellulitis. And the MRI showed proptosis of the globe along with endophthalmitis and involvement of the distal optic nerve as well within 3 to 4 days. So you can appreciate how aggressive this particular patient has presented to us with. The ophthal team had planned a surgery, but then the reference was given to us. So I'm assuming that Vineet, you will also manage this case with me. All right. So the question to us was, what do you do about the antibiotics? So like any other ID physician, both me and you, Vineet, we'll probably just look at the history of the patient, which we have already discussed. And after that, we will make a differential diagnosis of what are the plausible bugs in this setting. So whenever you have a periorbital cellulitis, streptococcus always needs to be kept in mind, isn't it? However, in this particular case, he did have history of community-acquired skin abscesses happening on and off. So, and with the rapidity with which he had presented with, CA-MRSA was one of the concerns that we had. We also understand that he had some Cinnaris oil spilled into his eye. And as soon as we have that, the usual bugs that we think of are usually Pseudomonas, Burkholderia. And because it was just so damn rampant, we were also a bit concerned about the fungal aspect as well, whether it has really come from that Cinnaris spill or something like that. Vineet, would you agree with these differentials?
Yeah.
All right. So now let's see how things work. So Dr. Vineet, he at least he is on the side of empiric therapy right now. So I guess I would say that you would probably want to start with meropenem to cover the Pseudomonas, linezolid to cover MRSA and possibly strep, and plus or minus lamb because the patient has such an aggressive disease. Well, me as a proponent of rapid diagnostics, I think even I would have started the same thing. This is the prescription that I had written for my patient as well. But because I love rapid diagnostics, I really wanted to understand the bug that we have. Now, please understand that whenever a patient is undergoing an ophthal surgery, you are never going to get your cultures positive ever. Itna chota sa, you hardly have 0.4, 0.5 ml of fluid. That is never going to grow. And in that particular setting, by and large, you have to really depend on your best case scenario. But now here we had a differential of the four bugs that we wanted, but we don't really have a rapid PCR specifically for ophthalmic infections. So what we try to do in this is we used a joint infection panel. So that has all the four bugs, except for the fungus. It has all the other bugs listed on that. And we can do it only on 0.2 ml of the sample. Yeah. So that was the thought behind it. And because vitreous is a bit gelity, it is a bit gel-like substance, you cannot really run it through the biofire. You require a liquid sample for that. That's why we had told the ophthalmologist that you take out some aqueous humor, and that is what we do the biofire panel on. Results. The biofire was positive for Streptococcus pyogenes. All right. And for the course, the amphotericin B had just come in. The patient had been rushed into the OT. He came out, and by that time, the amphotericin was just about to be started. We held it on. We switched the meropenem to ceftriaxone immediately, and linezolid was continued for the antitoxin effect because he had presented in such an aggressive manner. This was within an hour of the patient going into OT and coming back. And this is what rapid diagnostics can do. Vis-a-vis such vis-a-vis if we had no rapid diagnostics available, what would have been the future course of this patient? The patient would have been continued on the same antibiotics and antifungus probably. He would have been subjected to the high costs and the toxicities associated with that. And please understand that it's very difficult to really treat panophthalmitis. So he probably might not have even had a clinical response to that. We don't know that. So this particular regimen, the entire regimen would have continued probably for 21 days or something like that. However, with the use of this rapid diagnostic, I could optimize the treatment within an hour. And that is the power of that. And just to build on to this, so we wanted to understand, so BCID2 panel is a very popular panel in Indian ICU. And we have several papers to understand the microbiological impact of this panel in our setting. How well does it correlate with the phenotypic cultures? But what we wanted to understand is, does it have any impact on clinical outcomes? And the gentleman and the lady depicted here are Dr. Saidulu and Saili, my extremely talented and extremely sincere clinical pharmacists who did bulk of the work for this particular study. They have done a marvelous job. And the study has really come out well because of all the hard efforts from these guys. What we tried to do, so this was the PICO for our patients. We basically recruited ICU patients with a bloodstream infection. The intervention cohort was in 2023 when we had the panel available, while we used a retrospective control cohort when we did not have a panel available. And our primary outcome was time to appropriate therapy. I won't bore you with the details, but just in a nutshell, we had screened 380 patients. And eventually, after necessary exclusions, we had 257 patients in our intention to treat analysis. Amongst these, there were certain patients who were excluded because they were already on an appropriate empiric therapy, and so the patients did not have any contaminants which were treated. So eventually, our per protocol analysis at 153 patients, wherein an actual change of therapy was actually observed. Baseline characteristics, you don't need to go through the details of this. I would just like to point out that by and large, they were evenly matched, but there were more females in the BCID2 cohort compared to controls, and the control cohort had more COVID cases compared to BCID. This is our intention to treat analysis, a bit difficult to go through, but I'll try to simplify this for you. Whether it was time to appropriate therapy, whether it was time to microorganism identification, whether it was time to de-escalation, whether it was time to escalation, whether it was the length of stay in the ICU, or whether it was in hospital mortality, BCID2 cohort had a favorable outcome in all these aspects. All right. Lower time to appropriate therapy, lower time to escalation, de-escalation, organism identification. The ICU length of stay was 6 days in the BCID2 cohort compared to 9 days, so saving 3 days. All these were statistically significant. And in hospital mortality difference, you can appreciate it was 27.1 in the BCID2 cohort compared to 54% in the standard of care cohort. These particular results were also replicated in per protocol analysis. All right. Now, of course, it looks very good that BCID2 cohort has such a lovely mortality difference, but please understand that mortality is not just a function of a single parameter. How sick is the patient? How comorbid is the patient? Has the patient received appropriate therapy on time? There are several other factors which really influence mortality. So we tried to do a logistic regression analysis to understand what were the independent predictors of mortality, in which we found that a higher PITS bacteremia score, that sicker the patient, and if the patient had COVID-19. So these were the two independent predictors of mortality. Interestingly, BCID2 use, although an univariate analysis showed that it can reduce mortality, and even in this aspect, if you can actually observe, the point estimate is 0.31, basically indicating that it was responsible for around 70% reduction in mortality. However, this difference was statistically non-significant. Now, whenever we talk about statistical significance, what does P of less than 0.05 really mean? It basically means that whatever is the observed effect, the probability of it happening due to chance is less than 5%. In our case, the p-value was around 7%, 0.07. Does it really matter whether the p was less than 0.05 or less than 0.07? With these kind of outcomes that have come out with a mortality benefit of around 70%. Well, as a statistician, of course, it's important. It's a very big difference. But as a clinician, that small point of 2%, does it really matter? That's for all of you all to decide. Obviously, as Dr. Vineet spoke about, there are several limitations of the panel. It does not detect important mechanisms of resistance. Even if you have a CTXM E. coli, you can have around, at least in our study, we had around 25% of the isolates which had an ESBL plus pattern, that is resistance to piperacillin, tazobactam, and cefosalbactam, and does not detect porin, C-fluxes, and non-48 mechanisms which are responsible for Acinetobacter and Pseudomonas. So as Vineet said, that there are flaws for any rapid diagnostics because it cannot cover everything. But sometimes if you have the knowledge of that, you can actually inculcate that knowledge. Knowing what the panel cannot detect can actually help in making good clinical decision making for your patients. I would still take it even if my BCID2 panel does not detect it. I'm sure that those are not the targets that I'm looking for then. So as a pro rapid diagnostician, well, there is enough evidence. Now I can say that it promotes earlier targeted treatments and has a potential mortality benefit. However, there is no doubt a room for improvement. But wait, why should you just believe me? You have one of the most competitive inhibitors. Vineet is my dear colleague who's competing against me. Why not hear it from the horse's mouth himself? So when I was actually doing a literature search, look what I came across. This particular study published in the Indian Journal of Critical Care Medicine. And look who has authored it. Our very own dear Dr. Vineet. Look what he says. This is his own handwriting. He has written, I recommend that all ICUs should routinely incorporate this test, that is BCID2, in their antibiotic decision-making process and antimicrobial stewardship. Read it again, and he's given a big thumbs up to rapid diagnostics. So Vineet, I really am wondering that why are you really on the other side of this particular debate? You are probably on the same side as well as me. All right, I think that should be it. Thank you so much.
Thank you, sir. I think he's on the other side just because I asked him
I
to
know,
be
I
there.
know. Very unfair of you, huh? Very unfair of you.
So
Sir,
I have two, three questions. Like,
Tell me.
quite in ideal scenarios, there are good rapid diagnostic tests, but the problem comes when you see any unvalidated PCRs. For example, it may not be BioFire or it may not be tested properly. You may get 5 or 6 targets in. I think you would have seen this kind of PCR reports. So how do you deal with this situation? Because this is a situation which I think I see it once a month at least. So How do we deal in this kind of scenario?
So fortunately in our setting, because Hinduja has Dr. Rodriguez as the main proponent, we don't really have any non-validated tests with us. All of our tests are USFDA approved. So we really don't face a problem, but I understand that in other settings, this might be an issue. So in that particular case, for instance, if you look at the respiratory panel, the lower respiratory tract panel, it's choose out so much stuff. Now I had a patient who had come in with the community acquired pneumonia. The primary physician did an LRTI panel on that, and it showed Pseudomonas with an NDM, with a Haemophilus influenzae, with a Staphylococcus aureus, with no MECA gene detected. And he called me up to ask me whether we can give this patient cefiderocol in a patient who has come in with a simple community acquired pneumonia. You understand?
Yes.
Now, in this particular setting, the clinical settings comes into play, isn't it? This guy has come in with CAP. Possibly the problem here is Haemophilus influenzae only, nothing else. So in that case, we just tell him that this is not required. So that clinical interpretation that you spoke about, how do you clinically interpret those diagnostic tests? That is more important. But yeah, there are situations where it does become difficult, wherein you have so many things coming in, especially if the patient has been in the ICU for the longest time with so many bugs coming around. I think it's just your clinical aptitude which will really differentiate what to shove out and all those things, frankly.
The second thing is all these RDTs who come into the market, they should be validated. Otherwise, I don't think maybe it will be a big mess in future if all these RDTs keep circulating without a validation. Then we'll be stuck. See, it's not like every hospital should have biofare. A lot of hospitals don't have
Absolutely.
biofare. They do send it outside or to some lab because they want a rapid diagnostic. Sometimes the clinician will be very desperate to get a diagnosis. He needs to show some diagnosis to the patient attenders. This is one of the scenarios. So at that time, they desperately send these kind of PCRs and then end up with reports totally confusing. Second thing I had a question is, did your biofire recently miss any targets which were picked up in cultures? For example, it is
So
supposed
the,
to, the targets are available in biofire. One of the thing I do miss is, for some reason, I don't know why, it is Enterobacter cloacae. It has been missed a lot of times in biofire and culture has picked it up. So do you also encounter these kind of scenarios?
are you talking about the JI biofire then?
Yeah,
Or
prosthetic joint and the regular BCAD2
so
also.
what exactly happens? This even we have seen, but frankly, whenever the surgeons are operating, what they do, they take out some tissue from the proximal side, some tissue from the distal side, something from the anterior, something from the posterior. Now, if you in a diseased tissue, if you have sent the biofire, then it's fine. But now in a non-diseased tissue, so suppose that entire sample will go to micro, labeled as proximal, distal, anterior, posterior. Now, if the anterior tissue does not have the disease and you do a biofire on that, it's going to come negative. But the culture of the distal or the proximal tissue, which is disease, is going to come positive,
Oh,
which we have observed in our setting as well. So now what we have started doing is that whenever we are ordering a biofire, only the diseased tissue which we feel, that is the one which we use for a for that particular test. And sometimes what we are doing is sometimes more for the cost effectiveness, we try to pull up the samples. Anterior or posterior एक साथ रख लिया, medial or distal एक साथ रख लिया. You understand?
yeah.
On the basis of that, if you're able to pool the samples, the cost effectiveness increases. You are just doing two cultures or whatever, and the chances of the biofire picking up a disease sample becomes much higher. Not withdrawing the fact though that there is a small chance of failure rate. So even if you look at the study that we had done, we had around a 1% failure rate, wherein the blood cultures had picked up Candida parapsilosis, I think, but our biofire did not. So that was a proper failure because you have a target in it. But I think that is a fallacy for any rapid diagnostic that you do. There has to be some kind of a failure rate. Reassuringly, the failure rate is not very high. So that is a good sign.
I had
So
one
Vinit, are you pro
question.
or against diagnostics, by the way?
I would put it in this way. So, rapid diagnostics are useful if they are used in good clinical judgment. So, it should not be like practiced left, right for every patient. I
Hmm.
don't think it will have much benefit after 24 to 48 hours. If you really want to
Hmm.
benefit the patient in escalation or de-escalation, it has to be done in first 24 hours. Now, tell me, Dr. Umang, how often you're involved in first 24 hours of the admissions? It may not be
So for
possible for every patient, right? It may be
Absolutely.
after 24, 48, or even after 72 hours, when already organ dysfunctions have happened, and culture report may be just 1 or 2 hours, or cultures have been already sent. You're just waiting for it to flag. So at this point, when you know there is a mortality happening, and does this biofire will just add up on the cost. So I will put it in this state: if you are ordering a rapid diagnostic test, it should be in the golden hour.
Mm.
The golden hour, it may not help, especially in sepsis. But others,
So,
others again, the prosthetic joint infection, or we do have a lot of vertebral osteomyelitis. It is useful, as you discussed. We may have to closely discuss the orthopedic surgeon and spine surgeon to send a diseased sample, not a completely healthy tissue. A lot of times they will send the disease sample for the culture, and just the necrotic margin would be debrided and sent for biofire PCR.
so basically, to all fairness to the surgeons, I frankly feel that they feel whatever material they're sending is diseased. So but they cannot, matlab, macroscopically, they won't be able to understand whether this is diseased or not. At least you get some idea, but not the entire idea. But I agree with your statement altogether that we should use the RDT as soon as possible, but I would prefer that particular statement in the setting of sepsis. In terms of GI biofire, it's an expensive test. You're going to give this treatment for a period of 6 weeks. In that particular case, to use biofire upfront, I just have 2 or 3 indications, at least in a joint and infection area. If the patient is septic, wherein I don't have time to make decisions, I need the right treatment right away. If the patient has been already on several antibiotics before he's taken up for surgery, wherein I know that the culture yield is not going to be positive. In these two scenarios, I order it upfront. But in the other scenarios, what I do is I send an extra sample to the lab and I wait for 3 days till the cultures come up. If the cultures come up positive, then I don't need to use that expensive test for that patient. Albeit at the site of probably, I think I'm delaying my antimicrobial stewardship by a day or two. But in the long run, this patient is going to be on this treatment for a period of around 6 weeks or something like that. And logistically, to order a 25,000 or a 30,000 test, wherein it's not really going to change your clinical outcomes of mortality or whatever, not even mortality, even treatment failure, reinfection of the joint and all that, I don't mind waiting for those 24 to 48 hours till the time I get my cultures. But for sepsis, absolutely, it has to be done upfront.
The problem happens, you wait for this 48 to 72 hours. For example, if it is a osteomyelitis and it comes negative, then it is a very difficult job to persuade the surgeon for a rebiopsy or a reculture. This scenario I have faced multiple times. So I need to call the surgeon, tell the importance of sending for, as the cultures are negative. For example, they may not have sent for fungal culture, and you may have to do a rebiopsy and send that for fungal culture. At that point, do you send for PCR as well, or you wait for the?
I tell them that you take that extra tissue sample and keep it, store it in the lab. मेरे को अगर लगेगा तब मैं PCR बोलूंगा आपको, अभी मत करवाओ.
Oh, that's a good idea.
Once the cultures are coming negative in the next 2-3 days, then I ask for it.
Thank you. Thank you. I think it was a great learning experience, sir. And I'm extremely sorry for the delay. I think we exceeded by almost an hour now. So last point I need to ask to clear my head is one thing. So as you said, I agree biofire is a standardized test, but you ran a biofire which is standardized for joint panel with the aqueous humor. So how do you think cross the specimen standardization is? Because even I had planned to run in our setting, we don't have joint biofire. So I had planned to run the synovial fluid in a respiratory biofire, which our microlab didn't agree for.
So frankly, in our setting, we have found it to be very useful. So I understand that it's not standardized for that particular sample, but in dire situations, you need to use it. How are you going to standardize a GI biofile for an aqueous humor? Positive culture लगता है ना भाई. 0.2 ml में क्या positive culture आने वाला है? It's never going to happen. So in those settings, we coerce, we keep telling Kamila ma'am कि madam patient की बहुत हालत खराब है. Clinically indicated, वहाँ पे आप लिख दो, we try to coerce them that way. And that is how they do it for us. But yes, so we actually have diagnosed patients with HSV pneumonia, CMV pneumonia on the basis of a meningitis panel on BAL. So we have done that as well. Kruti is actually presenting that case in ECMID this year. So this is how it is. I think it's very, very useful. And in certain select situations, you should do that. Now, unfortunately, just because BioFire has not come up with that kind of a panel, that should not really impede our clinical judgment that we think it is this. And we need a diagnosis of this. That's how it is. I'm absolutely in favor of using off-label good tests. BioFire panel अगर आप use कर रहे हो ठीक है, मतलब standardized panel जो है. Non-validated PCRs is something that I would still be a bit sketchy about.
Because we
Thank
will
you,
not
sir.
know what target it will come. So unvalidated, it's
So that is the
your
clinical judgment. If you are using, for instance, nosocomial meningitis, for instance, उस वाले case में a regular meningitis panel is not going to give you the answer. What are the usual causes? It's going to be a Klebsiella, it's going to be an Acinetobacter, possibly a Pseudomonas, which is the panel which covers all three: joint infection. You cannot use a BCID2 panel here because BCID2 panel requires your culture to be positive. So the sensitivity of that panel is low compared to the GI panel or the meningitis panel. So that's how you either use a respiratory panel or a GI panel for this. And we have used it for our cases of nosocomial meningitis, wherein we have got the diagnosis as well.
Okay. I think we will end it. I think we can continue it some other time, the discussion. So again, I would like to thank Umang sir and Vineet sir for making time, and again for staying till the end, for being a part of this.
Thank you, Akshata. Thank you so much.
Thank you, Akshata and AMR, for giving me this opportunity. I have one request. Next sessions, you can inculcate this topic of irrational antibiotic combinations such as ceftriaxone sulbactam, ceftazidime tazobactam. They are a big problem. A lot of people don't know. To be frank, a lot of people don't know that this combination doesn't serve any purpose. So I think as AMR team, I think you may have to think about this topic also, about their opinions and how this is a big problem.
Yes.
A lot of people don't write ceftriaxone, they do write ceftriaxone sulbactam. So that's a big problem.
We had it in our hospital formulary names. I was like,
Then you have to get rid of it.
It's difficult. Okay, so we'll end today's session for now with this. So over to Afrin for further proceedings.
Thank you so much, Doctor, for your active participation, and all of the attendees and the panelists. Thank you very much for the active participation. And a special thanks to AMR Declaration Trust and the Managing Trustee, Dr. Abdul Ghafoor, for this impactful webinar series. Thank you. And we also extend our appreciation to Viatris and Pfizer for their generous unrestricted grants. Thank you so much. Thank you. Thank you, Dr. Akshatha. Thank you for your coordination. Thank you.
Yeah, thank you, Afrin and Mayank, for coordinating and bringing together this webinar and making it easier for me. So yeah.
Thank you, madam.
Thank you.
We're expecting more and more webinars from you. Thank you.
Sure. Thank you. Good night. Thank you for staying back.
Good night. Good night.
Minutes. One
Thank you, madam.
extra. Yeah. Thank you.
Thank you, Mayanak. Thank you so much.